our thing is we try to keep our graft size below 7.5 millimeters and try to implant it at the mid-stromal level, and the thickness we restrict it to below 150 microns. Thank you for your attention.
Thanks a lot, Madhu, for showcasing this new surgical technique. Would you also do this in eyes that have had cross-linking before, or would you prefer to do it in eyes where you will cross-link later? And would you also plan like a topo-guided PRK on eyes that you've done?
Yes, sir. Actually, already cross-linked eyes we did not do so far, sir, because these are the cases that are usually not eligible for cross-linking. So when the thickness is less than 400, this is the technique we do. And post this, we can definitely do cross-linking. And Rishi sir also suggested last time that we can do a topo-guided PRK in these cases to improve vision, that we still did not try to implement. Most of the cases were happy with the contact lens vision they had, so we didn't go actively to do any other surgical intervention in these cases.
Very nice. Dr. Rishi, Dr. Srinivas Prasad, any questions for Madhu?
I tried this in a couple of cases, but what I found is it's a little unpredictable, the outcome.
Sir.
And how can you be sure that unless you're using a femtosecond laser to dissect, how can you be sure how smooth your bed will be and how deep you're going? So in your series, what is the thickness of the lenticule that you're introducing?
It is somewhere between 90 to 150 microns, sir.
Okay.
But usually over a period of 6 months, they become compact and they end up being 70 to 80 microns.
So the premise is that the Bowman's membrane is giving some rigidity to the
rigidity, and the stroma is adding some volume, making the thing flatter and making them eligible for vision improvement with contact lenses.
So previously how would you contrast this with, people are also putting smile lenticules in?
Yes, sir.
How would you compare this with that?
I don't have a personal experience with smile, sir, but I think smile they'll not have the Bowman's layer.
They won't have Bowman's
layer, it's only the stromal part. So
for the smile lenticule, I think Sri Ganesh has published a technique called Philly, where he has taken the smile lenticule, but he punches out a central 3 millimeter opening. So it's like it becomes like a donut shape. So when you introduce this, it results in mid-peripheral steepening and a central flattening. So that can help provide some visual improvement as well. Yeah, maybe then you might decenter, but if you were just to put a biconvex like a smile lenticle that you put out, that may not work in this because it will still make the central part steeper. Yeah.
Do you have a pre-define the depth wise for the recipient?
Yes, sir. Actually, I did not show in the video. We have that guarded knife, sir, where you can assess the depth of the stroma, and then you can create your stromal pocket.
No, I'm talking of the recipient when you are doing a refining.
Recipient only, sir. Donor refine only, sir.
Okay, same one.
Yes, yes.
But the depth is not defined.
Here I did not show you.
Okay.
But we can use the guarded knife that we have, that 480, 500, 350 guarded knives, no, sir.
And you are introducing the lenticule through the limbus, no? Rather than...
Yes, sir. I do a scleral wound because it heals well when compared to a clear corneal wound.
But your this thing is, when you are making a pocket, it is through the corneal incision.
Yes, sir. Corneal,
and
but
you are introducing through the scleral one.
It's a corneoscleral tunnel, sir, like we do in an SACS, similar to SACS.
Any other questions from the audience?
Excellent surgery, Dr. Madhu. So, two things. One thing, what is the thinnest depth you went? What was the thinnest packing?
Thinnest we did until 330.
Okay.
330 we could achieve.
And second thing, did you ever try cross-linking the Bowman stromal?
Yeah. Few cases we tried. There's, not much of a difference. Even without cross-linking, they were doing good. In between, in 2-3 cases, we wanted to see if it had any additional benefit when we did cross-linking. But when we compared the result, they were not much of a difference.
Thank you.
All right, thank you very much, Dr. Madhu. So next up, we'd like to continue in the same vein and taking care of patients who have keratoconus, who have a complication that is not too uncommon, acute hydrops. And for that, we'd like to invite Dr. Sunita Chaurasia. Dr. Sunita Chaurasia is a consultant in the cornea service, the Shantilal Sangvi Cornea Institute at LV Prasad. And she's evolved a new technique of managing acute corneal hydrops, and she would be sharing her technique shortly.
The slides, please. So I will be talking on the management of acute hydrops, which is a complication of ectasias. Major cases are falling keratoconus, and while some can occur even after pellucid and other causes of corneal thinning. So when we look into the management, full screen mode please. All right. So the various management options of acute hydrops are conservative medical management using intracameral gas injection, compression sutures. Compression sutures can be applied in the form of full thickness or partial thickness. So I will be mainly focusing on the compression sutures part because this is a thing which we have shifted completely to managing these cases, but we should know which cases we have to do and which cases can be just left alone. So for this, I use this algorithm, and this is based upon the size of the hydrops and the cause of the hydrops. If the cause of the hydrops is pellucid, generally most of these cases do very well with compression sutures because it also has a refractive outcome in managing these cases. With respect to size of the hydrops in keratoconus, it's the grade 3 ones which require management. Otherwise, the grade 1 and grade 2 can be left alone with conservative management alone. Now, I'll spend some time on this to understand the concept behind the compression sutures. The compression sutures, if you look at the diagrammatic representation of hydrops in this case, and that's the posterior membrane, which is a DM, and the Duas layer, there's a split over there. So the partial thickness sutures, compression sutures as such have been described, but they have been described in the manner that to apply full thickness passing through the Descemet's membrane. But the modification, what works really well is using a partial thickness sutures, and the reasons for this is that when you have a grossly edematous cornea, passing sutures needle through the grossly edematous cornea is sort of very difficult. And plus, in addition, there are certain other problems which can be associated with full thickness sutures. Full thickness sutures can make the Descemet's membrane little taut, can cause more scarring. And when in thin corneas, when the hydrops resolves, when you remove the sutures, you can get a fistula tract which can start leaking. So these are the reasons why partial thickness works very well. Partial thickness means that the suture should be passing within the 60 to 70%, not involving the posterior membrane layer. And this is just to show what happens when you do the compression sutures. There's a compression effect because of the sutures, and the breach which was there, which is larger in the first cartoon, sort of gets resolved or becomes smaller after applying the compression sutures. The level of defining where your compression sutures are, the thickness, can be judged by air in the anterior chamber, and which at the end of the surgery can be left, can be just left to a very minimal amount or no at all. Now we need to do certain investigations prior to planning for the surgery, and these are pre-operative investigations on, one of them is the anterior segment OCT, which is very useful, and also the careful slit lamp evaluation. Now when we look at the slit lamp, we need to define where the site of breach is. How this is important, we'll come to it later. It may not be very relevant, but it is also still important to localize the site of the breach. Now in this particular case, we can't really localize where the breach is or based upon the slit lamp, but we can make out a relative area of central translucency. Probably the breach is in the center part of the cornea. Now look at this one, this is sort of little clearer. Here you have an area of translucent area over here in the inferior quadrant, and that is where the site of breach is. And looking at the OCT, we can make out this predominant anterior stroma is relatively still intact over there. Look at this picture. If you look at this picture, there's multiple loculi, and which can be made out on the slit lamp. And if you look at the OCT, almost the stroma in the anterior part is bare minimal. So this is one configuration we might see in some of the cases. Look at this one. This particular patient again has little advanced cone, and if you see, there's a lot of translucency in the center part, meaning that there's not much of stroma in the anterior part. Now, this is again important to understand because the way we apply our sutures will be dependent upon these parameters as well. How do we identify the posterior membrane tear? Can also be done intraoperatively in some cases by using an endo-illuminator. Now, basic principles, this is just common to all the procedures, so that is why I'm just spending some time on this. The guiding principles will be generally when we can identify the tear, we should be placing our sutures perpendicular to the site of tear just to make sure that it is more anatomically arranged when we apply the sutures. But there are several instances where we don't make out the posterior membrane breach. Now, it's not really hard and fast to have the orientation, but we have to just bring the compression effect by using the sutures. Like if you see in the figures, cartoons B, C, D, and E, where we do not know where the configuration of the breach is, one can apply from the periphery in the arcuate manner in the center part because we want to avoid passing sutures within the stroma. These are passed in an infinity suture manner or a mattress suture where the sutures in the center pass overlay, means over the cornea, not within the stroma. In the pellucid, since the breach is almost always crycentric, these have to be in the radial fashion. Now, just passing through some examples of cases managed with the similar technique as what we explained. So, initial part is to have a little amount of air bubble in the anterior chamber to know the level, and then here we are, because we didn't know where the site of breach was, passing from the periphery to the center, and then in the center, once we have most of the sutures in the periphery intact, we pass the sutures in an infinity fashion, and these sutures in the center will be in the overlay fashion, avoiding within the stroma. Once this is done, the air bubble will be released, and we will be replacing with saline followed by a BCL application as shown in this video. So, very minimal air, and this maneuver is just simply done to make sure that the DM comes in close proximity. And this is the day 1 picture, and this is the post-op day 3. We can see that the edema has resolved. And the peripheral sutures which are there, now they are redundant. We can remove all of these sutures in the periphery and just remain the center one intact for a later removal because the scar has to heal before we remove the sutures. This is one more case of a Down syndrome who had a 5 weeks history, extreme photophobia and near total eye drops. And this patient, again, we don't know where the breach is, but we know that it is a large one, massive one, and this boy was constantly rubbing his eye. So again, there's no localization of breach, but we are just trying to compress the anterior part of the cornea. And I'll just skip because the initial part is just the same. So over time, initial part, we may have to retake some sutures because it's difficult to pass the sutures in a very advanced eye drops. And as and when we keep passing sutures, we see that the edema has started resolving, and as and when we are nearing towards the conclusion of the surgery, it looks way better. And this is how it has been. We can see intraoperatively there's a lot of remarkable resolution of edema with the application of the sutures. So this is after 2 months, all sutures removed at the same time in this case because this had to be taken under general anesthesia. Another case where now again we can see that here the DM tear is all around circumferential in the mid-peripheral region, and we can see the circumferential tear in the on the OCT itself. Now here the sutures have to pass again radial to the perpendicular to the site of the breach, and this is a technique which was done again. Similar nature, we place an air bubble in the anterior chamber followed by suturing at the perpendicular to the site of the breach. So in this case, because it is almost circumferential, we have to apply sutures, and it looks like a lot of sutures, but then this is how it was. And this is the day 1 picture of the patient, and post-op 1 week, the patient had a good vision in the central cornea. Now coming to situations like this one, now here if we apply sutures in the routine way, there's a lot of cheese wiring which can happen in the center part of the cornea because there's not much of stroma here. So modification of this technique could be just simply to use a bandage contact lens where the sutures are passing over the BCL and not directly over the stroma. So this is one case where we attempted to use the bandage contact lens fashioned in 8 mm dimensions using a trephine. Initial technique is similar, putting an air bubble in the anterior chamber. The BCL is trephined to 8 mm dimension. And I'm showing this in this case as BCL, but I'm sure what Madhu has shown in the previous presentation, I'm sure the Bowman's membrane or with a stroma can also be used to sort of do a similar kind of technique. So here, mainly because the anterior stroma is very thinned out, we have placed a BCL, and the sutures are passing over the BCL to avoid direct contact with the sutures with the epithelium, which can cause cheese wiring effect. So this is how the suture was placed, and this is a post of 1 week. We can see the basic premise is to just bring the anterior lamella closer to the posterior membrane, and in this case, 1 month later, the sutures were removed and patient had a good vision subsequently with lenses of later on. This is a case of pellucid margin degeneration here because the tear is concentric. The sutures are applied in a radial fashion perpendicular to the site of the tear. And this is the same day picture. We can see a remarkable resolution. Now I'm just pointing out this particular case. This is another case of a pellucid which had high drops in the inferior region. Now in pellucid, generally the suture removal should be sort of delayed and may not be sort of removed as well, because for many months together, simply because when we do the placement of the sutures, it also serves a refractive power. This patient had, to begin with, prior to the time when he had high drops, his vision was 2250 with the contact lenses. He was improving, but not much. But when we do the compression suture, this really serves as a refractive outcome also for the pellucid patients. Now, this is another case which had a pellucid and high drops in the periphery. Following resolution in the inferior, he had in the superior region, and this is how the refractive outcome can also be tackled by management with the compression sutures. Thank you very much, and if there are any questions, I can handle them now.
Thank you very much, Dr. Sunita. Very skillfully done, and also looks like a lot of planning goes into each of these cases and not just applying sutures beforehand. Very nice. Any questions from the panelists, Dr. Srinivas Prasad, Chairman?
Yeah, because sutures are there, and quite often, as and when the edema starts resolving, the sutures will become loosened up. So the placing the sutures makes the eye very, very comfortable, and when the sutures are becoming loose, you remove them. Otherwise, if you don't have a BCL, the patient is quite symptomatic with that. That's, yeah. Yeah, because first of all, the talk is about high drops, that is why. Yeah.
That's when the patient comes.
No, I think it's very nice using a bandage contact lens, but if you are using it as an overlay, so you're not suturing through it, because if you try to suture through a contact lens, the sutures will sometimes cheese wire even through the contact lens. But using a smile lenticule or using just a thin layer of corneal tissue would also serve the same purpose, basically like doing a scleral buckling where you're putting a tissue and you're covering it with sutures, and that brings the anterior layers closer to the posterior layer to the break, and that seals. But I think one of the big advantages is that you don't need to keep gas or air tamponade for a long period of time. One of the disadvantages of doing that C3F8 or SF6 is that if you're not very careful, you can end up with a pupillary block, which can give rise to Ureth Zavalier and other complications.
Thank you. Any further questions from the audience or any members of the panel? Use a mic, please.
It's like using a diaphragm to shrink that.
Pellucid margin degeneration on both the sides. It has got a wonderful results because it induces some amount of fibrosis, which will help us. 2 of the patients have done very well,
Yeah, this is not in high drops. This is in regular
This
PMCD.
is a regular pellucid.
Yeah. Also, have you considered using any other suture material, Dr. Sunita, like proline that is more elastic, that probably gives more flattening, or you think silk works quite well? I'm sorry, nylon works quite well.
I think for some cases where you have to retain the sutures for a little longer duration, maybe in those cases, but otherwise tendo nylon has worked well for most cases. Like let's say for pellucid or some cases which are very thin cornea, where you want to retain the sutures for a little longer, maybe those cases we may want to.
Perfect. Thank you very much for those amazing videos. The chance of recurrence, The question is about recurrence of hydrops.
Recurrence. No?
Recurrence of hydrops in the same area? So recurrence usually, yes. So one of the important things is to make sure that the posterior membrane has healed. So because when we apply the sutures, it is just causing the compression effect. But the posterior membrane has to heal, and that healing will happen when the endothelium slides over there. That's a time-dependent process. So we have to wait for that length of time and monitor that. That is why the sutures which are there in the periphery where the edema resolves, you can remove them at 1 week. But the ones which are there in the center part overlying the breach, that has to be removed little later. So generally, I'll say for most cases, it has been around 4 to 6 weeks. And cases of pellucid, I'm just saying because they have to be kept for a little longer because the area is very thinned out and it is serving a refractive purpose. So unless a scar has become a little concrete or consolidated, better not to remove them early. So suture removal is important. Otherwise, if you remove sutures early, then you can again have the edema occurring at the same site again.
Any role for absorbable sutures?
Absorbable sutures, I don't think we have to have something which is should be non-absorbable rather. So because we need to retain these sutures until the time the healing has happened. Absorbable, at the most, we'll talk about vicryl. Vicryl will resolve in 2-3. It will not give that kind of an effect.
Okay, thank you.
Doctor, excuse me. Dr. Sunita.
One more question.
Here.
There.
How to assess depth for every case, like the depth of suture?
When we place the air bubble in the anterior chamber, we will be able to. So the purpose of initial air bubble is only making a side paracentesis and putting an air bubble is to know the level, because that gives the defined plane as to where your posterior membrane is. So air bubble in the anterior chamber gives that idea.
So should we go through and through the cornea?
No, that's what I'm saying. We can just go it above that plane, not necessarily involving the Descemet's membrane.
Thank you very much again. So next up, we have not Dr. Jagdish Reddy, but we have our scientific committee chairman, Dr. Rishi Swaroop. Rishi is going to be speaking about using his technique of doing deep anterior lamellar keratoplasty for corneal scars. Rishi.
Thank you, Praveen, for involving me in this fast session. Can I have my slides? I apologize for repeat of slides for those who were in the keratoconus session yesterday. It's essentially a lot of videos are going to be repetitive. Yeah. So I'll just run through the videos of DALC step by step so that we have clarity on each step. So as we all know, DALC is indicated for patients who have a problem in the stroma, and the Descemet's membrane, the endothelium is essentially healthy in these patients. So it could be scars, or it could even be dystrophies or any opacity in the stroma, and of course irregular corneas. Even therapeutic DALCs are done for stromal keratitis. So before you go ahead and do a DALC, it's important to understand the eye properly, understand how deep your scar is, and if your pathology is involving the Dua's layer or not. And that will help you kind of decide on multiple things like which technique to use, whether any additional procedures are required, what size of trephination should one do, should we just stick to an anterior lamellar keratoplasty or a deep lamellar keratoplasty is necessary, and should we anticipate any complications. So of course the patient should have a healthy endothelium. If the endothelium is not good, there's no point doing a DALC. It probably be better off doing a penetrating keratoplasty. So if possible, try to do a specular microscopy for all your cases. If you can't, at least evaluate the cornea on slit lamp, look at the specular reflex of the cornea, and if you can't see that also, just look for edema. If you don't have any clinical edema, that means the endothelium is functioning. So basically edema is seen by thickening of the stroma. Rule out other conditions like dry eyes. You need a good surface for a DALC to work, otherwise you will have a lot of surface problems after the procedure. So if you need to, you can do some plugs, etc. along with the procedure. Try to understand the extent of involvement, so that will help you decide how much of the cornea you need to remove. So I think pachymetry maps are quite useful in that, or some of the newer tomographers, but of course seeing on slit lamp itself will tell you a lot. Depth of involvement is also very, very important. If the pathology is limited to the anterior stroma, you could get away with just doing an anterior lamellar keratoplasty like a Falk, etc. But if it is a deeper pathology, then you need to do either a deep lamellar or a penetrating keratoplasty. Also the severity of the thinning, how much working space do you have, that will again help you understand which technique may work or may not work. Specific mention has to be made of viral etiology, because if you have a viral keratitis related scar, in these cases chances of recurrences are very high, especially if you leave behind some more stroma. So here you want to go as close to Dua's layer as possible, and if possible before surgery you should try to reduce the vascularization using procedures like fine needle diathermy. And of course antiviral cover has to be given, started before and continued for many months after the DALC. Finally, you have to see the involvement of the Descemet's-Duas complex. So if it's like an old hydrops like was in the previous case, you will have thickenings or irregularities in the level of the Duas layer, which indicate that the patient has had a old hydrops. And these cases you want to try avoiding going all the way down to the Duas layer, and you may want to leave behind a little bit of stroma. So that's a pre-Duas layer DALC. Earlier they used to call it pre-descemetic DALC. Also look for other features like atopy or patients with Down syndrome, etc., who are likely to have surface problems after surgery. OCT is a very useful tool to understand the depth of your scar and whether it's involving the deeper Duas layer. Instruments, I just use a routine keratoplasty tray, but there are advanced instruments you can use. Trifines, you can use handheld or vacuum trifines. So vacuum trifines have the advantage that with every turn you know how much you're going, so your initial trifiniation can be controlled. You can have lamellar dissectors which are available from various vendors. You have big bubble cannulas to if you're interested in doing a big bubble technique, or you could even use a 27 gauge needle. Scissors are there for excising the stroma safely, but I use a routine universal corneal scissor itself. So it's not necessary to have these, but it makes the surgery a little easier. Various techniques have been described. Big bubble technique is a popular technique in which basically you introduce a bubble of air in the deep stroma. This bubble is like a whitish bubble with a translucent center, and basically it opens up the potential space between the stroma and the Duas layer. It will keep expanding till about 8 or 8.5 millimeters. It won't go till the periphery, and that's because the peripheral Duas layer is attached to the stroma, so the bubble won't expand till the limbus. This is the typical big bubble. It's also called the type 1 bubble. Sometimes if you inject the air in the wrong space, or if there's some pathology, it may not go into the pre-Duas layer space, it may go between the Duas layer and the Descemet's membrane, and that's called a type 2 bubble. That looks more like a water bubble, I'll show you in a later video, and it can extend till the periphery, so that also gives you a clue. So once you've obtained the big bubble, you can remove some stroma, about 50-60%, and after that you can mark one area and make a brave slash in that area. So you use a sharp blade and make a puncture into the, so this is not as brave as it should be a little more jerky. And you can put a drop of viscoelastic to kind of just make the exit of air a little safer. After that you could put viscoelastic into the space that you opened up, and then excise the stroma using blunt tipped scissors and expose the Duas layer. Then you trifine the donor button to the appropriate size, peel off the Descemet's membrane and endothelium, and then you just put the donor button in its bed after washing the bed. Sometimes if your trifiniation is eccentric, you may have a little bit of arcus on one side, so turn the graft and put any arcus that you may have under the upper lid. And then you can suture with either interrupted or combination of interrupted and continuous sutures, whatever works for you. So if you have a good healthy endothelium, you can see as early as first or second day, your cornea becomes quite compact and clear, and patient can even start seeing very well very early post-operatively. And you can use poor quality tissue and still get an equally good result because it's the endothelium that really gives the clarity. So that is about the big bubble technique. The other technique which I employ is called the groove and peel technique. It's a manual technique, and I'll just describe that as well. There are various other techniques as well, but these are the two techniques that I use. So in this technique, what we do a partial thickness trephination in the cornea, and then we use a scissor dissection to spiral all around along the trephination edge into deeper planes. So you may do 1, 2, or sometimes even 3 rounds, and eventually you will reach the glassy Duas layer. And once you start seeing that, you expose about 2-3 clock hours of that layer. You grasp that central island of stroma. You can give counter pressure at the limbus if you want to. And then using stretch forces distributed over a large surface area, you can peel the stroma very easily off the Duas layer. So essentially we have not done any dissection in this area, but the stretch forces will help to open up this potential space quite easily. And giving counter pressure also is very useful. So you can get a very nice clean bed as good as you would get in a big bubble DALC also, and the outcomes are comparable. So you can see this representative picture of a patient on first day itself. Graft is very clear and compact, and the interface is smooth. So this is a patient of brittle cornea syndrome in which after reaching the desired depth, when you try to lift, the whole stroma just peels off quite nicely. You have to be of course careful, there is a risk of rupture. You can use femtosecond laser assisted cuts also to do the same thing. So in this particular case, a mushroom cut has been done with a femtosecond laser, and then we used a big bubble cannula to get a bubble, and then of course rest of the surgery was as like any other DALC. And the good thing is that even the donor cornea can be trephined with the femtosecond laser, so you get a perfect fit of the donor corneal stromal button. And it fits like a manhole cover and induces lesser astigmatism, and it's easier to suture as well. So this is one patient who had a femtodalc for keratoconus, and you can see 1 week itself the cornea became very clear and the patient started seeing very well, and 1 month this is how the eye looked. For therapeutic DALCs also in selected cases like acanthamoeba, it works really well, and you can just peel off the entire stroma quite easily, and this patient actually had a cataract surgery later and did well. This was another child that I managed at LV Prasad who had a surface burn along with stromal scarring, and we did a pre-desmetic DALC. In this case I just used an iris repositor to remove most of the stroma, and we did a layer by layer peeling in this particular case because it needed a large limbus to limbus graft, and along with that we combined a cultivated limbal epithelial transplant and managed to give the patient a good cornea with an excellent surface. This was one of the patients with macular dystrophy, developed suture-related infection also, but eventually got 20/20 vision. So do I have, since Jagdish is not there, can I take a couple of minutes more? Yeah. So I'll just show a few challenging situations. Sometimes when you're trying to get a big bubble, you may not get, the air may not find its way to the correct plane, and you may end up with the emphysema like this. So it's not the end of the world. You can take off a layer and either attempt the bubble again. So here you can see that there was a bubble starting, but the emphysema covered that area, so we're not sure what's happening underneath. So what you can do is take off the layer, and then you can see a partial bubble is there, and you can do this little small bubble test by putting a small bubble in the antechamber, and when you rotate the eye, it goes around the big bubble. I'll show you that again. When I'm moving the eye, you can see that small bubble in the AC moving around the big bubble, which is basically like an indentation of the Duas layer into the AC. You can also combine it with a cataract surgery. So in this case, the stroma has been completely removed and the phaco is being done with just the Duas layer there. And you can see it's quite a tough layer, it doesn't really easily rupture. And you can safely do a cataract surgery even after removing the entire stroma. So this is one particular case where the brave slash was in the beginning stage, I was a little aggressive, and after the air had come out, I continued cutting and I cut the deeper layer as well. So this can happen if you're not careful, but it's not the end of the world. So in this case, we put a small patch of stroma along with fibrin glue to seal the perforation, completed the dissection from the other side, and then later put the stromal button, sutured it partly, and then from the interface I teased out that little bit of stromal patch that I had put to cover the perforation, and after that the patient did really well. Even in the groove and peel technique, sometimes you can have perforation if it's an old hydrops or scar, but most of these perforations are small and they can be managed very well, and you don't really have to convert to a penetrating keratoplasty. This patient in fact later went on, had a topography guided PRK and got 20/20 vision and did really well. So I'll just show you the type 2 bubble which I had talked about earlier. So in this case there's a dense scar in the cornea. So you can see that at the outside you have like a water bubble. I'll just show you after, removing the stroma. You can see this water bubble which is extending till the periphery. That's a type 2 bubble. And in this case, this is the first time I'd got a type 2 bubble, I think. So I went ahead and removed the stroma. So this is not a very wise thing to do, because underneath that you only have Descemet's membrane, and that can easily rupture on touch, even with just a suture if it touches. So in this case I was lucky. I managed to dissect the entire stroma off and got a very clean bed because it was only Descemet's membrane. But probably not a good idea to do this. So DIALC is the gold standard for surgical treatment of isolated stromal disease. Although big bubble is preferable, manual DIALC may be a good alternative in advanced scenarios. Most challenging situations in DIALC can be overcome to complete a successful deep lamellar keratoplasty. Thank you.
Thank you very much, Dr. Rishi. Couple of questions from the audience, if anybody has anything to add, or amazing collection of cases as well as surgical technique for DIALC. So, go on please. There's a mic here, right here.
Rishi, how are you controlling that depth, when you are dissecting it? That I am unable to understand.
So it is by feel, but we have guarded trifines which you can use, or even the vacuum trifines. Every quarter turn there's a fixed amount that the trifine goes in, so you could use those.
Okay.
Yeah.
Nice.
Yes.
Dr. Rishi, so in your groove and peel technique, I've seen this video on YouTube as well. So you have a special scissors, I believe.
Yeah. So Joja has made that.
That. So you use that to guard, to go to that depth?
Yeah, it's actually very nice for this technique because it is got a narrower tip, so it's easier to introduce, and it's got a flat profile, and the tip is also blunt, so the risk of perforation is very less. So you could take that if you want.
And it's just that you just keep going round and round, and when
once you start seeing the Duas layer, it looks different. It's shiny. There's no fibrillar attachments of the stroma.
That's basically where you stop.
Yeah, so that's when you stop. Expose 2-3 clock hours. At that point, you can just give counter pressure and pull. And if if you're getting resistance, that means you're not at the Duas layer. You need to dissect some more.
And have you tried this in post hydrops healed scars as well?
I have. So if it's like a very focal old hydrops or a deep scar which is coming in contact with the Duas layer, I'll come to that point last. I'll dissect all around, and in that area, I'll do it very tentatively. And if I'm getting a lot of resistance, then I will probably just shave it off with a blade rather than try to rip it, because in that area you may get a perforation. So if it's eccentric, it doesn't matter so much. Also, I forgot to mention, you have to make a paracentesis before you do the peeling. When you are very close to the Duas layer, it's a good idea to just decompress the eye with a paracentesis. Yeah.
Thank you, Rishi. So we'll move on from the anterior stroma, starting from the Bowman's membrane to the stroma. Now we'll move on to endothelial transplants. So first up, we have Dr. Shalini Singh. Dr. Shalini is a consultant in the cornea refractive service at L.V. Prasada Institute, and she's going to be speaking about Descemet's stripping endothelial keratoplasty, or DSEK for short, for endothelial dysfunction.
Very good morning, everyone. So at the outset, I would first like to thank TOSCON and Dr. Praveen for giving me this opportunity. So in this presentation, I'll be taking
While we are fixing this, Dr. Rishi, I just had a question. So the groove and peel technique, I think it's an amazing technique, but I wanted to know, is there a possibility of having some stromal fibers retained once you reach? Is there a possibility there? Because
yeah, if you're not at the correct plane, you will not have stromal fibers, you will have lots of them left.
Yeah, so have you done this for dystrophies, particularly the granular dystrophies, because they tend to have a recurrence if we leave behind.
Yeah, so any DALC, if you do in a granular dystrophy, you can have recurrence of, even if you do a big bubble, you can have recurrence of the dystrophy in the interface. So that's a risk you are taking. In general, I think most granular dystrophies don't really require a DALC. The superficial ones can be managed by PTK, etc. And the regular ones, I think, I don't think there's any case where the opacities are so dense that you need to do a keratoplasty in a large number of cases. I think very few cases where you really need to do it.
So in this presentation, I'll be taking you through various surgical videos and better understanding of anterior chamber dynamics in complex size and how do you overcome those hurdles while performing DSEC. So we all know that the most popular technique for posterior lamellar keratoplasty today are DSEC and DMEC, with DMEC becoming more popular. But recently, like till 2017, a paper published by USA group where it has been noticed that even now, DSEC remains the surgery of choice in eyes with complex anterior segment anatomy. Hence, moving forward, we all know that for a more simpler cases or more straightforward cases with a better anterior chamber, DMEC would be the surgery of choice, but DSEC still is preferred for eyes with complex anterior segment anatomy, especially in a country like ours. According to the recent published data also by the LVP group, where we noted that 78% of endothelial keratoplasties accounted for DSEC. So this is one of the patients presenting with pseudophakic bullous keratopathy. So in this video, as you can see that one of the haptic of the IOL is still present over the iris, and there is a vitreous strand which is present extending up to the side port made previously during the cataract surgery. Hence there was a broad-based pass present. So initially, to begin with, it is very important to ascertain the position of the IOL, and the IOL haptic which is present over the iris needs to be repositioned well. Releasing the pass, broad-based pass are very difficult to reposit because iris tissue itself has a good memory. It has a tendency to form again. Hence, you should not be very vigorous as this can lead to damaging the iris tissue and also even iridodialysis. Excessive bleeding which is caused because of this pass which is formed can be addressed by placing a large bubble like a tamponading agent. The centration of the tissue, as you can see in this video, while trephination of the donor tissue should be checked by the marks which are placed on the eye bank, because some of the times if there is an eccentric trephination and the centration is marked by trabecular meshwork, you might end up outside the cap which has been cut. Thorough interface wash is extremely important, especially in cases like this where you can see that there is excessive bleeding present, especially from the tunnel side. So after the lenticule has been placed inside, you should slowly remove the glide without removing out the lenticule, and a thorough interface wash, because this interface wash is important. There might be some debris present if it is not washed thoroughly, which can lead to glare, and sometimes that remaining in the visual axis could decrease the visual outcomes itself. Air bubble, when in this video you can say that when it's placed from one of the side port, has a tendency to escape behind the IOL. Probably there was a PCR during cataract surgery. Hence, it is better to attempt the air bubble under the lenticule from the other side port. One suture should be placed before you go ahead with further maneuvering, and then enlarge the same air bubble. You can see when we did from the other side port, we achieved a good size air bubble. In DSEC, it is very important that you do not have to place a very large air bubble like in case of DMEX. Just an air bubble large enough of the size of the lenticule and an adequate amount of IOP should do the job. This is another case where a patient had pseudophakic bullous keratopathy with ACIOL. In cases of doing DSEC with patients who have ACIOL, it is difficult, especially the air bubble management, because if you tend to overfill the anterior chamber with your air bubble while trying to tamponade the lenticule, the air bubble might escape through the ACIOL behind, and then it becomes a vicious process where ultimately you will end up with iris not behaving and exerting vigorous pressure. So just adequate size of air bubble, as I mentioned earlier, and with adequate intraocular pressure. Now intraocular pressure can be achieved by air bubble also and by saline. And as you know, saline is slightly heavier. It goes into the vitreous cavity and gives you the adequate amount of intraocular pressure so that you can close the case. Now this is one more patient where patient had presented to us with pseudophakic bullous keratopathy with completely deficient iris tissue. Patient had undergone SF-IOL around 6 months back, and he presented with gradual loss in vision. He reported that he had good vision post-surgery and slowly the vision declined. And as you can see in this photograph, that patient has a quite thickened epithelium. So removal of the hypertrophic epithelium itself improves your visualization, especially when your view to anterior chamber is poor. Debriding it off will improve your view and better surgical outcomes. In cases of, in this case, you can see that when the surgeon is trying to remove the DM, he has disturbed the posterior stroma. So not tugging more pressure on the posterior stroma and probably trying to remove it through a vitrector will also reduce the amount of scarring which is caused by disturbing the posterior stromal fibers. In patients where there is the iris tissue deficient, it is better to insert the sheets glide completely because that acts like a support. Although there is IOL, but peripherally there is a lot of deficient areas from where sometimes during insertion of an air bubble, the lenticule can just drop into the vitreous cavity. So the sheets glide will help to hold the lenticule in place. And with the sheets glide in place, placing a small air bubble between the glide and the lenticule will just hold the lenticule against the posterior stroma. As you can see that the surgeon is continuously inserting air bubble and it is escaping behind in the vitreous cavity. Sometimes this itself can also help us that you just put an air bubble enough to which covers the vitreous cavity and then you can place an air bubble in the anterior chamber. But if you have not achieved adequate intraocular pressure with it, if the eye appears still soft, because these are the cases where there has been extensive vitrectomy done, you can raise the pressure or intraocular pressure inside the eye by placing saline. This is one another patient who presented to us 3 months after the surgery. He had undergone cataract surgery and 1 month after the cataract surgery, he underwent PDEC. It is extremely important to time endothelial keratoplasty after cataract surgery. Done immediately or very soon, within 1 to 2 months, will compromise the outcomes of your graft and survival of the graft. So after this patient presented to us, we waited for another couple of months for the eye to become quiet. And then we went ahead with surgery. So as you can see in this, the patient has undergone PDEC and there is extensive peripheral anterior synechiae present. And the IOL, one of the haptic of the IOL was present over the iris. And in the center, it is not very clear because of the thickened epithelium. In the center, there was a proline suture placed because the iris tissue was also severely damaged during surgery. So the proline suture was placed to do a pupilloplasty. The moment side port entry was made, during this surgery, the proline and the AC shallowed, the proline suture just immediately gave away and the IOL was extremely unstable. The IOL had to be explanted as that suture gave away and one of the haptics was already above the iris tissue at 3 o'clock and at 9 o'clock, it was present just hanging entangled in the bag. It had to be explanted, after which a thorough anterior vitrectomy was done. There was no adequate support to place either an ACIOL or an iris claw lens in this case. So we went ahead and did a aphakic DSEC. So these are some of the tips and tricks, especially managing your DSEC patients in complex anterior segment anatomy like PAS, aphakia, or where the iris tissue is completely absent. Thank you.
Yeah, thank you very much, Dr. Shalini. In view of the fact that we are running out of time, we'll go on to the next talk. And next up, we have Dr. Rajesh Fogla, who's going to be talking about the other technique of endothelial keratoplasty. He's going to be talking about DMEC for endothelial dysfunction. Again, Dr. Fogla needs no introduction. He's a senior consultant at the Cornea Clinic at Apollo Hospitals. And if you want to see more of his videos, you can see him in half an hour from now when he'll be delivering the oration.
Good morning, everybody. Can I have the slides, please? Yeah, I'll be quickly touching about performing DMEC in post-cataract surgery corneal edema. Now, this is a 65-year-old male who underwent a cataract surgery and then developed a TOS and had, mid-dilated pupil and corneal edema. So in DMEC, when you do the surgery, I think the edematous epithelium, if you remove it, it helps improve your view. Otherwise, later on when you're going ahead with the surgery, the epithelium tends to get fragmented and anyway may require removal later on. We make 2 paracenteses to access the anterior chamber, and following that I'm putting in some pilocarpine to try and see if I can constrict the pupil, but you can see that there is a distorted pupil, there is some peripheral synechiae that's preventing the, and usually if you get TOS, you do get a mid-dilated pupil that's not very responsive. We make a clear corneal incision about 2.75 to 3 millimeter. You can do that through a scleral incision as well. The next step is to try and do the synechial using a cyclodialysis spatula. Be careful when you do this because often the synechiae, if they are too tight, you can end up creating an iridodialysis and it can induce bleeding. The stripping of the decimates is, as what it was shown in the previous video, is similar to doing it in DSEG. You can do it under cohesive viscoelastic or you can do it under air bubble as well. Here I'm doing it under Helon. Once you have broken the peripheral decimates, you can use the reverse Sinski and strip the unhealthy decimates membrane from the host cornea. Remember not to roughen the stromal surface at this point. You don't want a very irregular inner surface. So sometimes staining with trypan blue can also be done to help identify the broken edges, and you can do that also to identify the peripheral tags that may be remaining. To avoid contact between the DM scroll and the IOL, we decided to bring down the size of the pupil. So you can do that by doing a pupilloplasty using a Seepser knot. So we went ahead past a tenoprolene, which has a straight needle. You can introduce that and railroad it out through a 26 gauge needle. Once it is brought out, you can do the typical 4th row pupilloplasty where you put 4th rows and you close the knot. So there you can see that even when you are doing this, be careful when you are, because the tendency is that you may pull the iris too much, and if you feel there is significant amount of resistance, avoid, because you can have the peripheral iris tear from the root and you have bleeding. We do an inferior peripheral iridectomy. Here I am using a vitrector to do the inferior PI, but you can do that surgically through an inferior vertical paracentesis as well. You need a PI because you're going to use air or gas in the anterior chamber for long duration, so you want to avoid a pupillary block, so you need a patent inferior PI. After that, all that cohesive viscoelastic from the anterior chamber, the blood, fibrin, whatever is there is washed out, and then we do a test fill of the anterior chamber with an air bubble. And we leave the air bubble there for a few minutes. That helps also control any bleeding that you may have induced, or also reduces the amount of fibrin that can form. Then we move on to preparing the donor tissue. You can get pre-stripped donor tissue from the eye bank, or you can prepare your own. Here we are preparing, so we do a 10 millimeter partial punch, following which the peripheral edge of the DM is lifted. Then we peel the donor DM, at least 50 to 60%. After that peeling has been performed, this has to be done in a very slow, gradual manner without any kind of undue pressure, because the decimus is very fragile. After which, on the stromal side, we use a dermal punch, a 2.5 or a 3 millimeter dermal punch to create a stromal window. The decimus is floated back into position. We flip the donor cornea over. The stromal window is opened up. We dry the Decimet's membrane surface, and then we put in a S or an F stamp. This stamp helps us identify the orientation of the donor scroll once it is placed inside the anterior chamber. That's very important because once you place the donor scroll in the anterior chamber and you unfold it, you need to be sure that whether it's the right orientation. So if you put in letters like S, F, or P, you can identify that. Then we go ahead do a desired 7.5, 8.5 millimeter final punch, stain it with trypan blue for a minute or two. Then we can load it into a glass or a IOL injector system. The insertion usually in most cases is fluid based. So you are basically flushing the donor tissue into the anterior chamber. The AC maintainer that's been connected here, I use it to allow the egress of fluid from the anterior chamber when I am inserting my donor. That way there is no tendency for the stromal, the donor DM to rush out of the main wound, or the orientation of the scroll is also maintained. You can see that the chamber is not very tight. We secure the wound first before we go ahead and start tapping. Once you have secured the wound, then you keep the chamber partially formed, and using a cannula you can tap either outside the graft, and by using that tapping motion outside, you create fluid waves which allow the DM scroll to open up. You can see that you don't need to be very aggressive. You can gently get the DM scroll to open up. Sometimes you can use two cannulas, one to fixate and the other one to tap. Once it is opened up and it's fairly well centered, you can then put an air bubble below it. Here we are shallowing the chamber further so that we don't get the edges scrolling up again. There are several techniques, there are several maneuvers that we do depending on the configuration of the anterior chamber. If you have a very deep anterior chamber, you may have to use an air bubble over the DM scroll to try and get it to open up. If the donor is upside down, you have to flip it over using a small burst of fluid. In this case, it's been fairly simple. So let me just try and see if I can forward it a bit. Yeah. Once it is done, you go ahead and you ensure that your cannula is below the donor DM and not above it. So you see that the cannula turns blue, and once you place it in the center, you can put an air bubble and you can fill the anterior chamber, and you can look at the orientation. We see the orientation, the F stamp is seen there, and we know that it's in the right orientation, and that's pretty much the end of surgery. So I think it's a very wonderful surgical technique that restores the corneal anatomy back to normal. So if you see a post-DMEC surgery cornea on slit lamp, you might even miss out that the patient has had an endothelial keratoplasty. And because the biggest advantage is that the risk of rejection is almost 20 times lower than penetrating keratoplasty. So your use of long-term steroids can be reduced. You can move them onto softer steroids much faster, and the long-term survival of the graft also may be better. And the refractive outcome in terms of giving you, it has the fastest outcome in terms of the visual recovery and minimal refractive shift, even if because you're not adding any significant tissue to the host cornea. And worldwide, most surgeons are now using DMEC as their preferred choice of endothelial keratoplasty. Thank you for your patient hearing.
Thank you very much, Dr. Fogla, and apologies for running over time. If you would like to ask questions, you can always do that one-on-one after the session. So we'll end the VAST session right now, and would like all the speakers to please stay on stage to collect your certificates and then do a quick photograph before we disappear. So request Dr. Srinivas Prasad to give out the certificates to all the attendees. Dr. Sunita Chaurasia. We'll just do one group photograph. I think we'll just do one group photograph. Dr. Rishi, Dr. Fogla, Dr. Fogla, let's get all the certificates and then give out one.
voice video. So after the announcement.
Good morning, everyone. We are moving on to the important oration session now. I request Dr. Bharat Kumar, our President of TOS, to come onto the stage. Past President Dr. Badrinarayana and Secretary of TOS Dr. Rajlingam to come on stage for the oration talks.
Taste कर लें? वो जब
Our first oration is the Ravi Kumar Reddy oration, and we have a very special guest this year who will be giving the oration. His name is Dr. Jagdeep M. Katriya. He is an innovator par excellence, and I'm sure you'll all enjoy listening to his oration. I request our Secretary, Dr. V. Rajlingam, to introduce the orator of the day, Dr. Jagdeep M. Katriya.
Thank you, Dr. Rishi. It is my privilege to introduce Dr. Jagdeep M. Katriya, who has his own setup on the name of Akshadeep Eye Hospital in Bhavnagar, Gujarat, and he has professional excellence, and his career and work experience was very enormous. Among them, very few things I am going to read. He is a solo private practitioner since 1989 at Bhavnagar. Then he had lot of experience in many surgeries actually, but he had 65,000 of cataract with IVL surgeries in his credit, and 5,000 anti-glaucoma surgeries, and 5,000 around pterygium surgeries, 500 plus keratoplasties, and 7,000 plus LASIK and ASIC surgeries he has done. So he got an award of Dr. Dalit Singh Innovation Award in 2023 by ISM SICS, and he had lot of innovations like autofocus pro IOL, that is ringless progressive IOL, then OmniGlow, that is stereo coaxial illumination device, OmniGlow glaucoma drainage device, then UV glow ultraviolet device for C3R, then OmniGlow Supra, so suprachoroidal shunt for glaucoma drainage, then Video Glow, that is hardware, firmware and software to record, store, categorize and retrieve and edit surgical videos. Among them, and Stello Flow, that is autoclavable and reusable cassettes and tubings for Bausch & Lomb Stellaris Phacomission. Then MaxiGlow, so a device to rally see presence of maxifloxacillin. Then Lazaro X, laser-based toric axis marker. So there are so many glows he has invented. It is very useful in the field of ophthalmology. Apart from this, his professional excellence, he has an extracurricular activities like he did extensive work and 2,000 plus webinars on UV light and methyl blue against COVID-19. So he is a good and popular writer of Gujarati literature. With this brief experience, I invite Dr. Jagdeep Katriya to deliver your lecture. Thank you, sir.
Thank you very much, Telangana Ophthalmic Society in general, and Dr. Rishi Swaroop and Dr. Badrinath in particular. And what I am presenting to you today is not only me, but on the behalf of Dr. R.C. Shah also. I would like Dr. R.C. Shah, an eminent and leading eye surgeon from Bombay, who is my research partner in every innovation which we have done. And since there are so many innovations covered, I would like these to be presented as a voiced video. So I'll just start. And hello dear friends and colleagues, It is a great pleasure as well as honor to be amongst you all today. Our financial interests. At the outset, we convey our gratitude to Telangana Ophthalmic Society and namaste to you all and to all faculty. Today, I am very happy to present the prestigious Dr. Ravi Kumar Reddy oration on the joint behalf of myself and Dr. R.C. Shah, and my respectful pranam to Reddy sir. The tradition of conference and senate orations was started about 2000 years ago in Athens, Greece, by the great Socrates, his disciple Plato, and his disciple Aristotle. Our respects to them too. All our innovations are divinely inspired and profusely blessed by our Guru Param Pujya Pramukh Swami Maharaj and Param Pujya Mahant Swami Maharaj. Our Sashtang Vandan to them and all other mentors. Our topic today is cultivation and inculcation of innovative mindset, especially for YES, the young eye surgeons, for which we will present few of our innovations today. Let us first understand the difference between invention and innovation. The word invention is derived from two Latin roots, in and venture, whereas the word innovation is derived from two roots, in and novation. Invention is when something is created or made for the first time, whereas innovation is improving it to higher and higher levels. For example, the light bulb was invented by Thomas Alva Edison in 1880 and was serially innovated by Philips, Osram, etc. In our own field, the IOL was invented by Sir Harold Ridley and then were innovated by countless innovators. Dr. Charles Kelman was the inventor of phacoemulsification technique and machine, which has undergone a series of profuse innovations. Innovations can be as simple as making a metal frame to hold all your foot switches in a married state, so that from superior incision seating, when I move to right or left temporal, all foot switches move in tandem without losing our foot reference. Or converting any wired foot switch into a cordless one, or a BSS bottle near empty alarm, which will alert us when last 100 ml is remaining, or a phaco needle sharpener, which can not only resharpen, but it can also change the tip angles from 30 to 0 or 45 degrees or any. Or making Stella Flow, our autoclavable and 1000 times reusable cassettes and tubings for Bosch & Lomb Stellaris anterior segment phaco machine. It can be as simple as adding OmniGlow lights to the LASIK laser machine, where illumination is always very suboptimal. On the other hand, innovations can be as complex as renovating or rejuvenating or making your own entire homemade excimer laser. In 1988, I purchased the state-of-the-art Carl Zeiss Jena OAP 311 chair unit and immediately realized the immense benefits of it. And got inspired from it, we made India's first chair unit, and you will laugh at me, but we modified a Hajam's chair for the purpose. And then in 1989, we made a company named Plantech Medical Systems to make it commercially available. We did not patent it, so in next 5 to 7 years, many other companies copied it. Plantech was also the first to make a motorized OT table with a foldable footstep in 1989. This is a Sony 3D Handycam, having two optical channels for right eye as well as for left eye. I removed the optical head from my Zeiss slit lamp, replacing it with Sony 3D Handycam. So now I can see patients' eyes on a big 3D TV and can relay and record also. I don't need to stretch my neck or eyes on slit lamp. Coming to our most popular, most useful and most successful innovation, the OmniGlow, which is a stereo coaxial illumination device having its own dual lights which can be fitted at the bottom of any surgical microscope, which will convert it into a Lumira eye-like stereo coaxial illumination. It is quick and easy to attach and detach OmniGlow, and when fixed with a single bolt, it becomes integral part of the microscope. With OmniGlow, omnipresent, homogeneous and uniform and full red reflex with greatly enhanced stereopsis is 100% guaranteed in any position or any tilt of the eyeball. And OmniGlow is now complemented with Video Glow, which is just a 50 grams matchbox size micro head full HD video camera which is inserted directly into the beam splitter without any C mount or L mount or DSLR mount. It can record videos and photos in laptop and or desktop, and also can simultaneously live stream to multiple monitors inside the OT as well as outside the OT in conference or waiting room. It can also do live streaming on YouTube. With OmniGlow, we never need blue dye for capsular axis except for white mature cataracts. Not only we can see, but we can also record with video glow what the surgeon sees in exact and in vivid and beautiful colors. Hydro procedures, phaco procedures, nucleotomies, cortical and capsular cleanup are all so well visible that it boosts the surgeon's confidence and morale to handle even most difficult cases, even at senior age. In spite of our own aging eyes, more than 3,500 surgeons are all so very happy with OmniGlow, and many senior surgeons have actually postponed their retirement plan after having OmniGlow. PCR, drop nuclei, and endothelial cell loss have decreased to almost nil after having OmniGlow. With OmniGlow, we get full and homogeneous red reflex even in 2 mm or 1 mm pupils in any tilt of eyeball. Even in nearly mature white cataracts, we still can perceive good red glow, giving us a confidence that vitreous behind is clear and that there is no posterior polar defect. Visco wash is not only clearly visible, it is so beautifully recordable, washing out debris in front as well as from behind the IOL. The combination of OmniGlow and Video Glow gives nice smileys, not only on patient's eyes and face, but also on surgeons and entire staff's face. The space pack ISRO or NASA level optics of OmniGlow and Video Glow allows us to see and record the capillary blood flow, the RBC clumps and plasma flowing in corneal venous vessels as if a line of red ants is walking or like a river flowing on the Mars. UV Glow is our UV device for C3R cornea collagen cross-linking for keratoconus. UV Glow is essentially a UV avatar of OmniGlow. UV Glow gets attached to the bottom of the current surgical microscope, so there is no need for a separate stand. The microscopic surgeon's view is available to the surgeon throughout the procedure. There is a comfortable 200 mm working distance. Video recording of the surgery is possible and it is very cost effective. Live surgery display, relay and live streaming is also possible. And MoxyGlow is our very low power avatar of UV Glow, which makes moxifloxacin into fluoresce and glow like phosphor or radium. This is the syringe containing Moximix. We enter the eye, always remaining in front of the iris, and inject the Moximix till the entire chamber is full and the Moxi starts overflowing from the side port, and then we hydrate the side ports with the same solution. We can see Moxi going into the corneal stroma around the side ports. Then we check the intraocular pressure, which should be around 20-22, and that is the last step of the surgery. Our another very useful and important innovation is Autofocus Pro IOL. Autofocus Pro, a unique and novel ringless polyfocal progressive IOL which gives excellent vision at all distances, far, near and intermediate, without haze, halos and starburst, which is completely free from negative dysphotopsia. Autofocus Pro looks almost like a monofocal but works like a multifocal. It is an aspheric polyfocal progressive lens without any diffractive rings. It is static and fixed in the bag. There is no mechanical pseudo accommodation, but yet it functions like an autofocus lens and hence the name. Lifeline Millioptics Autofocus Pro is available as both options, as hydrophilic and as preloaded hydrophobic. This silky, smooth and soft IOL's injection is very easy, as good as any other soft foldable IOL. And as you can notice, unfolding is gentle and slow, and once both haptics are in the bag, we have to rotate the IOL so as to keep both dialing holes in upper half of eye, keeping the IOL horizontal as best as possible. This is the typical post-op fogging over refraction chart, and as you can see that from +2 to -4 the vision remains almost the same. This is the typical DOF chart of this lens, which is nearly identical to a teenager's natural lens DOF. For this, we at nearly retirement age enrolled ourselves in a polymer chemistry institute and learnt right from raw powders and liquid chemicals how to make IOL material sheets and to make blank IOL buttons from those sheets of soft hydrophobic as well as philic, and also learned how to make precast molded buttons. Autofocus crystal is the world's first PMMA multifocal IOL made mainly for MSICS surgeons. An autofocus HR is 9 mm optic, foldable and 3 mm incision injectable lens. The suffix HR stands not only for high resolution but mainly it is to commemorate Sir Harold Ridley. Terigo is our another innovation, which is a 21 mm diameter big soft BCL for glue and stitch free pterygium surgery. After the limbal stem cell autograft has been transplanted in situ, now with a wet cotton tube swab, we take out the Terigo BCL from its bottle, which is then invertedly spread over the cornea and graft flap. It is like spreading a king size big bed sheet, so we will need at least 3 or 4 hands to spread it. So the scrubbed assistant has to help the surgeon in this step. The Terigo BCL covers all the 3 sides, donor area, graft, as well as corneal epithelial defect. So there is almost no pain or foreign body sensation, and all 3 sides heal much faster under the shielded protection of the Terigo, and the surgery also becomes faster, usually taking only 5 to 10 minutes. So this is a cut, paste and cover surgery. Terigo lens is also very much useful in almost 15 other indications. OmniFlow is our another very important and very useful innovation. OmniFlow is a unique, novel, small and the best glaucoma drainage device, which is a sutureless short shunt to drain aqueous humor from anterior chamber to the retrobulbar space. A microvalve tube pressure regulator is fitted inside a soft flexible silicone tube, which controls the outflow of the aqueous humor, which will prevent hypotony and maintain IOP between 10 and 24/7 without or with minimum number of topical anti-glaucoma medications. This is how OmniFlow tubes look. This is the anterior chamber end, this is the retrobulbar end, and the retrobulbar end contains the tiny valve inside the tube. After putting L cut in the conjunctiva and after a little blunt dissection, insert a vectis to reach the retrobulbar space, which is very easy. We can insert almost 40 mm of vectis which goes into the retrobulbar space and creates a track. A gentle bipolar cautery is done. Now we make one scleral tunnel, which is made by angled MVR 20 gauge, 7 mm away from the limbus at 45-degree angle. The tunnel is now lubricated with viscomethyl. The beveled end of OmniFlow is now inserted in and passed through the scleral tunnel. 3/4 length of the tube is pulled out. The valved end of the OmniFlow tube is inserted into the retrobulbar space. It goes quite easily as if a rope is falling into the well. The excess length of the tube is pulled back and pushed into the retrobulbar space. Now a second scleral tunnel is made, which is radial or perpendicular to the limbus, about 2 to 2.5 millimeters from behind the limbus, which is then entered into the anterior chamber, bisecting the angle between the endothelium and the iris. The beveled end of the tube is now inserted into the anterior chamber via the second scleral tunnel. Only the bevel goes into the anterior chamber about 1 millimeter or 2, maximum 2 millimeters. Then the excess bend of the tube is pulled back, and which is then pushed back into the retrobulbar space. The firm anchoring of the tube is confirmed by vigorous pull, push and sideward movements, and as we can notice here, no matter how much we nudge, the tube will not budge. Tube cannot be pulled out unless we want to pull it out. It's firmly anchored, it's not going to migrate, it's not going to move on its own. Now we put fibrin glue and the conjunctiva is reposited back. The entire surgery for this is sutureless, and it takes only about 10 minutes to do the surgery. OmniFlow Supra is another version of OmniFlow. OmniFlow Supra is a suprachoroidal tube shunt for BAGS, BAGS, that is bleb-free ab externo glaucoma surgery. It drains the aqueous humor from anterior chamber to suprachoroidal space. With the OmniFlow tube grasping forceps, we now insert the tube in the tunnel and enter it into anterior chamber, only about 1 millimeter inside. And as soon as the tube is in, IOP will come down. Please notice the controlled release and slow flow of aqueous humor. After cutting out the excess length, we can now insert the rear end of the tube into the suprachoroidal space. Please don't worry at all. This is very easy and a completely atraumatic step. Tube goes in as easily as a candle in cake. We can safely move the tube little back and forth to adjust the length. With OmniFlow, the IOP is down from 60 to 80 to 10 to 12 as soon as the tube is in. The microvalve regulates the IOP, keeping always about 10 millimeters of mercury. It gives excellent results in all severe, intractable, bloody and oily open angle glaucomas. It is a quick 10 to 12 minutes, almost sutureless surgery. It is easy to learn and master. OmniFlow is made by and is available from Excel Optics, Chennai. In fact, we need and we request for a separate oration next year on these two types of phenomenal OmniFlow tubes. Mention, which is a laser augmented slit lamp for non-touch marking of the horizontal x-axis. After taking the patient on laser X slit lamp, we press the foot switch and aiming beams are powered on, and then after alignment of aiming spots at 3 and 9 o'clock position, with second press of the foot switch, laser flash shots are fired and markings are done in microseconds. With the blessings of Dr. Shigeru Kinoshita of Kyoto University, Japan, we did good work on chemical endokeratoplasty. Using a special and specific Rho kinase inhibitor, we can induce controlled mitotic cell division in corneal endothelial cells in cases of PBK or Fuchs dystrophy. We need full separate oration on this topic also. During COVID, Coronash was the UVC device we innovated, with which we can instantly kill all viruses in nose, sinuses and ears, and also in throat. This device not only saved us, but it also saved thousands of doctors, MRs and patients. Also during high peaks of COVID, under the able guidance of Dr. Deepak Golwalkar, we fearlessly treated thousands of patients with oral, intravenous and inhalation of methylene blue. We also did more than 300 webinars on UV and methylene blue for crusade against the COVID. And our this makeshift homemade wooden ventilator using Ambubeg circuit saved countless lives till the official high-tech ventilators came in the government COVID hospitals in enough numbers. This was powered by a car's wiper motor and a servo controller power circuit with small Raspberry Pi mini computer with software control buttons. Recently, we also learned innovative way of growing high quality, high yield organic saffron in-house. Beyond ophthalmology, we have devised a method acronymed as SLIM to prevent and reverse obesity and metabolic syndrome. In essence, inventions and innovations are hard and smart work to turn ideas into reality, which is really the greatest bliss of our scientific life. And in the process, more and more we learn, so more and more we earn. Not only money, but more importantly, the love and respect. Please scan this QR code to see full-length detailed videos of our innovations. Thanks a lot for your kind attention and patient listening. Thank you.
Thank you, Dr. Jagdeep Kakadia. It was really very, very inspiring, and I didn't know that you invented the first chair unit. That's really in India. That's really, really nice to hear, and so many amazing innovations. And all of us are benefiting from it, especially OmniGlow. I think a lot of people are using, and of course this Autofocus Pro looks very promising. Just one question I'll ask you on behalf of everyone. What is the secret behind all these innovations that you do? And then we'll move on to the award presentation.
See, when we were all young kids, we made toys from clay. Then we grew a little, then we started making toys from Lego. And little older, we all made toys from Meccano. And most of the people stopped making toys after the age of 12 or 13. I just continued.
Lovely. Thank you. I request all the chairpersons to come and give the award to Dr. Jagdeep Kakadia.
Thank you. And since Dr. Ila, my better half, she is the prime inspirer for most of the innovations which we have done. And most of the innovations which I have done are actually the sparks in the mind of Dr. R.C. Shah. He calls me in the middle of the night, aisa karna chahiye. And then I start working because I have a workshop and I have the mechanical team at my disposal. So with permission of President Sir, I would like Dr. R.C. Shah and Dr. Ila also to come on stage and stand besides me, because they are equal participants of all these innovations. And Rishi, this is only half of the innovations. So maybe for the remaining half, you can invite me for the next TOSCon. Thank you.
Thank you. We'll move on to the next oration. This is a special one to me because it is being given to my teacher, Dr. Rajesh Fogla, and the oration is named after another inspiring figure, Dr. Harikishan Goretyala. So the oration topic is the evolution of corneal transplantation, and Dr. Rajesh Fogla has been an innovator in corneal surgery and has been an inspiration to an entire generation of cornea specialists, not just in India, all over the world. I'd request the President, Dr. G.R. Bharat Kumar, to introduce the orator.
Good morning, everybody. It's my proud privilege to introduce Dr. Rajesh Fogla. So, he is Director Cornea Clinic, Senior Consultant, Apollo Hospitals, Visiting Professor in University of Argentina, Visiting Consultant to Kuwait, Sri Lanka Hospitals. He is a founder member and past president of Cornea Society of India. He is actively involved in instructing courses at various international, national fellowship programs, training courses in the cornea over the past few years. Routinely is conducting courses in AAO, ASCRS and ESCRS. Numerous publications in peer-reviewed journals and presentations at many national and international conference meetings. Reviewer for international journals of the corneal is international journals, corneal reviewer for many international journals. So he achieved awards at AO, APO meetings. He gold medals for intracorneal implants and refractive surgeries of India, and he is the first person to do LASIK surgery at Sri Lanka, and now Dr. Fogla is going to share his insights on the evolution of the corneal transplantation, which promises to both informative and inspiring. And now I welcome Dr. Fogla to deliver his oration.
Thank you so much, sir, for the kind introduction. Good morning, everybody. At the outset, I would like to thank the Telangana Ophthalmic Society for honoring me with this Harikishan Goretyala oration lecture. I'll be talking about the evolution of corneal transplantation, which has been my prime area of interest. Now, corneal transplantation surgery refers to a surgical procedure to replace the unhealthy corneal tissue with partial thickness or full thickness healthy donor corneal tissue. And we see that in various forms, as we have heard the speakers in the previous session, whether it's penetrating keratoplasty, deep anterior lamellar keratoplasty, or endothelial keratoplasty. If you look at the evolution of corneal transplantation, the first corneal transplantation surgery was performed by an Austrian surgeon, Edward Zim, in Austria, and this was back in 1905. This was in a patient who was bilaterally blinded by chemical injury, and the donor tissue was obtained from a living donor who had a blind eye, so they had to remove the eye, so they used the cornea for this surgery. Then, for a long duration, for almost about 30 years, the surgery was performed using only donor tissue from living donors, and that limited the overall number of surgery that can be performed. The Russian ophthalmologist Filatov suggested using cadaver donor tissue, and that opened up, the surgical options for many more patients. And Peyton developed the first eye bank in New York back in 1944. Prior to that, the lack of use of antibiotics, steroids, and poor understanding of the corneal immunology, the surgical outcomes were not very good, and only about 20% of the grafts survived. Then we had the introduction of the operating microscope, the surgical suture, the 10-0 nylon, which was And all these improved the outcomes to an extent that we started seeing success rates of almost up to 80% grafts remaining clear following corneal transplants. We had Arkila describe the air injection for doing a DALK procedure. And in 1998, Gerrit Mellis described the endothelial keratoplasty, which was called as posterior lamellar keratoplasty. In the US, Mark Terry described it as deep lamellar endothelial keratoplasty. So my introduction to endothelial keratoplasty started after that when I visited him. Mohammad Anwar described the big bubble DALK, which again gave rise to the big bubble DALK procedure that we are routinely perform. And among the endothelial keratoplasty, it's the work of Mellis, Price, Mark Gorovoy, that they introduced the concept of doing decimet stripping and performing the DSEC procedure. And Gerrit Mellis, with his innovativeness, introduced the DMEC procedure back in 2006. And currently, DMEC is the most popular technique. Kinoshita has been working for almost more than 2 decades on cell culture, endothelial cell culture, and very soon I think we will have cultured endothelial cells, which will again revolutionize the endothelial keratoplasty surgery further. Now, when we talk about penetrating, so these are the various terms that you may come across: penetrating keratoplasty, superficial anterior lamellar keratoplasty, DALK or deep anterior lamellar keratoplasty. DSEC stands for decimet stripping endothelial keratoplasty. DSEC is for decimet stripping automated endothelial keratoplasty. DMEC stands for decimet membrane endothelial keratoplasty. And you also have the artificial cornea or the keratoprosthesis. So these terms will be used later on in the talk, so I thought I'll just lay the foundation for that. In penetrating keratoplasty, we use a circular trephine or the femtosecond laser to excise the host cornea, a full thickness disc, and replace it with allogenic donor tissue. Use viscoelastics to protect the endothelium, and there is a direct apposition of the host and the donor using 10 nylon sutures. And post-operatively use topical steroids and antibiotics to ensure that the outcome is good. And if we look at the data from the Eye Bank Association of America, despite all the new procedures being there, still there is a large volume of penetrating keratoplasty being performed. And even in India, if you ask the most frequent type of corneal transplantation, it still stands at penetrating keratoplasty. So we do perform it for full thickness corneal scars, for corneal infections, and for any conditions where a selective replacement of the corneal tissue is not possible. Most cases do well, especially Fuchs or pseudophakic or aphakic bullous keratopathy. The long-term outcome from the cornea donor study shows that a major proportion of the grafts remain clear at 10 years. If you have coexisting glaucoma, that seems to be one of the factors that can result in undesirable outcome. And if you have lower cell count, the graft survival it tends to be also lower. So there is a direct relationship between the endothelial cell count and the long-term survival of the graft. So what are the problems that we face with penetrating keratoplasty? Unpredictable astigmatism is one of the most limiting factors where we are not able to give the patient correction because you have to wait for the graft edges to heal. With the sutures becoming loose or broken, you can have infections or you can have vascularization which can predispose to graft rejections. And any trauma can result in opening up of the graft-host junction, which can sometimes result in loss of the graft. So that came in, the thought process about doing anterior lamellar keratoplasty, wherein you preserve the host endothelium. And here, there is no risk of endothelial rejection, so you don't need to use steroids too often. So my introduction to lamellar keratoplasty was with this guy called Chad K. Rostron. He was at St. George's Hospital in Tooting in London. And in '96, I had gone to take my FRCS exams to London. And I spent a month with him. And that month when I was with him, that's the first time my experience with lamellar keratoplasty. He used to take lyophilized corneal tissue on a cryolathe. He used to fashion them, and then he used to use them for lamellar keratoplasty. And I was amazed to see extremely good outcomes in a wide variety of cases in his clinic. And that actually evoked interest that, this is something that we have to go back. Because at that point of time, if you talk to people and ask about they used to say, no, it's all dead and gone. We only penetrating keratoplasty is the gold standard. So I would say that my interest in lamellar keratoplasty is attributed to this guy in London. And I do meet him at meetings, and he still goes around doing his original technique. If you were to do a superficial anterior lamellar keratoplasty for corneal scars which involve the anterior 1/3 of the cornea, you can do them either using the microkeratome or you can use the femtosecond laser to do that. With the microkeratome, we describe the two-stage technique. In the first stage, we make a flap, and then we put the flap back, and the second stage, we go back and we cut out a central smaller trephination within the flap, and we replace it with donor tissue, and that results in pretty clear cornea. The advantage of using the femtosecond laser is all this can be done in a single step, because the edge of the femtosecond laser cut can be made into an inverted cut or a perpendicular cut, so that you can place your donor tissue much more easily. A deep anterior lamellar keratoplasty, wherein more than 80 to 90% of the stromal tissue is removed, that's pretty good, and it can be done for virtually any condition of the cornea where the endothelium is healthy. And Anwar described the big bubble technique back in 2001, where you introduce a 27 gauge needle, and as you inject air, it creates a plane of separation between what was thought between the stroma and the decimus membrane, and that's with me, with Mark Terry, Mohammed Anwar, and Shigeto Shimura back in 2006. So what we thought that by injecting the air, we are creating a separation between the stroma and the decimus membrane, and then we would excise all the stromal tissue and replace it with a donor tissue devoid of the decimus membrane, and these are the various steps. And so as we went along, I developed some instruments to help simplify the process so that other surgeons learning the technique can perform the surgery much better, which included the air injection cannula, the pointed dissector, the fixation forceps, and the stromal scissors. In 2013, Professor Dua from UK, he described the presence of the predecimus layer, which improved our understanding of how the big bubble DALC works and the different type of bubble that it performs. We also described the modification of the big bubble technique, where if you continue to inject air to enlarge the bubble, there comes a point where the pressure within the bubble can increase and you can result in a spontaneous rupture. So to minimize this, we described the two-stage procedure where you do an initial creation of the bubble, release aqueous from the side port, and then you go ahead and enlarge the bubble to the desired size. The introduction of the intra-op OCT has further made it easier to perform these procedures, because in real time you can see at what plane you are working. Femtosecond laser allows us to create various shapes, and that allows better apposition of the graft-host junction. You can customize the shape of the graft, and with the introduction of OCT, it makes it even better. So this is with the Z8 that we currently perform. You can see that we have applied the femtosecond laser on the eye. We make the cut, the anterior lamella of the tissue is removed. That's about 250 microns of the stromal tissue. Then into the tract that we have created with the femtosecond laser, you can introduce the cannula and inject air to create a big bubble. So you don't really need to go and find a plane. This plane is created by the femtosecond laser itself. And once you have done that, you can excise the residual stroma and then fashion a graft that looks pretty much the same like what you have removed from the eye. So it's like a jigsaw puzzle that the two layers join together very well, and you can end up having a very good outcome in post-surgery. So that's how it looks post-femtosecond laser-assisted DALC. And if you are not able to do a big bubble, then you can do a manual DALC, or if you have attempted multiple air injection and you have failed, then you can use these kind of instruments, the stromal dissector or the stromal pocket forceps, to create a plane, and you can peel off the stromal tissue. Basically, this is a modification of Malbrand's peeling technique. That's how it looks post-op. So even in the presence of hydrop scar, you can go ahead and create multiple. This is something we published back in 2005, where we used the DALC procedure along with conjunctival limbal autograft to restore the corneal clarity and ocular surface in eyes with chemical injury, and most of them were children, and we had very good outcomes in that. This is a patient almost 17 years post-procedure, and you can see that the DALC graft and the ocular surface is still very well maintained. In infections which are not responding to treatment, there may be a role for performing a deep anterior lamellar keratoplasty, such as acanthamoeba keratitis. Even in post-keratitis, like in this case, there is a perforation which is sealed with glue and amniotic membrane. We were able to go back and do a DALC, and you can see that at 3 months, the patient has 6/9 vision with a good cell count. Extreme ectasia like keratoglobus, where doing a conventional corneal transplant is difficult, you can do a large diameter sclerocorneal graft a lamellar graft and restore the corneal shape and function. That's the patient's topography post-surgery. Peripheral thinning, like in extensive marginal degeneration, also you can do a large diameter lamellar graft. We also looked at the role of using gamma irradiated corneal lenticules, which can be stored at room temperature, whether they can be used for lamellar keratoplasty, and we had pretty good outcomes in the 6 eyes that we performed it. A majority of the indications are either ectatic disorders or corneal scars, and you can see that the outcomes are pretty good. In a majority of the eyes, we were able to perform the big bubble technique. Multi-surgeon results in this paper also show that despite surgeons having different kind of experience, whether you are a beginner or you are an experienced surgeon, you can still have at least about 80% of your patients can achieve 20/40 vision post-surgery. You do have the complication of having a detachment of the posterior layer, but that can be managed very easily by inserting an air bubble. The other procedure, endothelial keratoplasty, where you selectively replace the diseased endothelium, is minimally invasive compared to penetrating keratoplasty, faster visual recovery, better refractive outcomes, and reduced risk of rejection. You can see there is an increasing trend among corneal surgeons to perform endothelial keratoplasty. Again, you have the DLEK, which we started off with. You can do DSEC or you can do the DMEC procedure. On the OCT, you can see the DMEC has the best corneal anatomy that's restored because the donut is only about 10 to 15 microns thickness. Back in 2003, I visited Mark Terry in Portland, Oregon, and that's Herbert Kaufman in the center picture. So we were there to learn and understand this procedure. Came back and we started doing the DLEC procedure back in 2003. And that's the patient we can see with a pseudophakic bullous keratopathy where a DLEC procedure has been done. And at 8 weeks, the patient has 6/12 vision or correcting to 6/6. We did conduct the first international meeting on lamellar corneal surgery back in September 2004. This was with the idea to try and popularize the lamellar keratoplasty. We had both Mohammed Anwar and Mark Terry present with us as faculty at the meeting. In the initial results of our endothelial keratoplasty, the average vision improved to about 6/12 and the corneal thickness was about 553 microns. But the best part that the refractive outcome was very good and your astigmatism was only about 1.5 diopters. In endothelial keratoplasty that we currently perform, we basically remove the unhealthy host Decimus membrane, either in the viscoelastic or air. And this is usually slightly larger than the size of the donor disc that you are putting in. You do need to perform an inferior peripheral iridectomy to avoid pupillary block because we use air or gas tamponade to hold the donor disc in place. The donor tissue can be prepared manually for DSEC or you can use the microkeratome. The advantage of using a microkeratome is that it gives you a smoother cut and a faster visual recovery. Insertion can be done through a 6 millimeter incision using a bent needle, or you can use dedicated inserters like the Busing Glide or the Macaluso inserter, and you can pull the donor disc in through a 3 to 4 millimeter incision. That's how the patient recovers. You have a complete air fill. By the 4th or 5th day, the cornea starts looking clear. In about a week or 2 weeks, the patient achieves almost 6/9 or 6/6 vision. This is a patient, 7 years follow-up. You can see that the cornea looks pretty good with a good cell count. And it can be done in a wide variety of indications, from Fuchs, pseudophakic bullous keratopathy to failed grafts, post-trab. One of the complications is the displacement of the donor disc, which can again be managed using air bubble. Again, looking at the outcomes, yes, you have good outcomes. Endothelial cell loss is only similar to penetrating keratoplasty, but a majority of your patients achieve 20/40 or better. Even at 5-year or 10-year, the cell counts are similar to what you have with penetrating keratoplasty. DMEC I started doing back in 2009 after Melis had described it in 2006. And this was pretty good experience, and worldwide you can see that more and more surgeons are going ahead with DMEC. In the US, you get eye banks giving you pre-strip, pre-stamp, pre-loaded grafts. Our eye banks have also started providing the pre-strip donor, which will make it easier for surgeons to perform. In terms of preparing the donor, we describe this illuminated base where you can visualize the Decimus membrane as it is being peeled off. This will also make it easier to strip the Decimus and identify any tears or damage to the cornea. Insertion, yes, we described a technique of using AC maintainer as an egress point, which allows the donor scroll orientation to be maintained, doesn't get expelled from the eye, and you can unfold it pretty easily. And same thing, you use a tamponade, you see post-op, by the 3rd or 4th day, the cornea starts becoming clear, by 10th day, you have a good outcome. We also published in congenital hereditary endothelial dystrophy, which in the pediatric population, patients present with bilateral corneal edema. So we looked at various, role of the anterior segment OCT, the outcomes, and there is a new finding of corneal folds that we described. So all this was done recently, a couple of years back. If you do get a detachment, you do need to perform a rebubbling, which can be done in the outpatient department, and the detachment rates can vary between 8 to 10%. Similarly, for anterior lamellar keratoplasty, with the intra-op OCT, you can look at the decimate scroll, and in DMEC, it's quite useful because even in corneas which are hazy and not clear, you can use it as an instrument to assist you in your surgery. As with surgery procedure, training is also important. We describe a modification of the artificial chamber model so that we can teach the DMEC procedure to aspiring corneal surgeons. And since 2008 at Apollo, we have been conducting our courses every quarter, and we have trained over 350 surgeons in various forms of lamellar keratoplasty so far. And if we compare penetrating keratoplasty with DSEC and DMEC, we find that the penetrating keratoplasty has a risk of wound dehiscence. The dislocation rate is more with DSEC or DMEC and not seen with penetrating keratoplasty. But the best corrected vision is far better with DSEC and DMEC, and the risk of rejection is the lowest with DMEC. And there is hardly any hyperopic shift that you see with the DMEC procedure. Future, we have the cell cultures and pioneering work done by Shigeru Kinoshita from Japan. So you use the cultured endothelial cells along with the rho kinase inhibitor, and you can treat the endothelial dysfunction using this. So basically, in conclusion, corneal transplantation techniques have significantly evolved over the past 2 decades, and currently lamellar surgical procedures have definite advantages over conventional penetrating keratoplasty. The use of femtosecond laser and intra-op OCT have a promising role in improving the surgical outcomes, but the future is for tissue engineering. It may be expensive, we are not sure when it will see light of the day, but when it does come, it will make all these earlier surgical procedures redundant. In conclusion, I would like to thank all my colleagues who have, over the years, we have discussed and we have debated and we have tried to improvise all the procedures that we do, and also to my family, because I've been traveling to meetings and they have allowed me to be away and to participate and to interact with everyone worldwide. Thank you for your patient hearing.
Thank you, Rajesh. Excellent presentation. Please join us to take your presentation.
Thank you, everyone. Now we move on to the very exciting OPL. There's going to be a lot of fun and entertainment, and I request the chairpersons or the hosts of the OPL to take over, our very own Dr. Manoj Mathur and my dear friend Dr. Harshul Tak from Jaipur. Please stick around for some non-stop entertainment and science.
They'll come. Excuse me.
Request, content, yeah. Request everybody to come in. We are starting OPL. Request all the judges, Dr. Nankishore, Dr. Madhukar, Dr. Vidya, Dr. Subhadra, Dr. Malika. We need three more. Many we have to start. Dr. Manoj ko. Ravi Kumar, Badrinaran sir. Hello. Sir. टीम के मालूम चले ना नाम कौन. Hello, check. Okay. Yeah, you take this. Madam, good morning. Dr. Badri, you will be scoring for the entertainment value, impact, technical, this thing. Huh? Score for technical. Dr. Ravi. Hi, good morning. Organizers. Big boss. I give 1, 2, 3. So 3 videos are there. I will be Snail, we'll play ready? It later. You can start. We'll adjust. Wait. 2 को क्यों किया है तुमने? 2 को क्यों किया है? Request all the umpires to take the stage. 50 seconds. We are missing Dr. Ravi. कहाँ है? Ravi Kumar. Dr. Vidya. So after my video, when I say, we need to start on time because Cyberabad people always they are in a hurry, fast track. So the team captain needs to fly out. Ravi, come quick. We are missing one more empire. Charuta empire. Empire. Come on, Badri sir. Ravi, you will be scoring for the overall impact, entertainment value. Okay. Science will be scored by 1, 2, 3, 4, 5, and Vidya, Badri, and you will be scoring for impact, overall impact. Huh? Score out of 10. Yeah.
I'll say, आज के आपके होस्ट टाइम करें बड़े मियाँ छोटे मियाँ आप उधर से आएंगे मैं इधर से
Yes.
No match fixing allowed here. Please go in pavilion.
He is coming and
Judges,
trying to influence us
note.
before the pitch report. We have to just show the pitch report first. Harshal, the pitch looks decent enough. I think it's a flat turf, not many cracks. Okay, it should be a belter, a high-scoring match for sure.
Let's see. So good morning, TOSCON 2024. We present to you Ophthalmic Premier League. और आज आपके होस्ट हैं स्नेहल, बड़े मियाँ, छोटे मियाँ.
कोई हमें प्यार करे, कोई जान निसार करे. कोई हमें प्यार करे, कोई जान निसार करे. देख के हमको तो कहते हैं लोग भला. बड़े मियाँ, छोटे मियाँ सुभान अल्लाह. बड़े मियाँ तो बड़े मियाँ, छोटे मियाँ सुभान अल्लाह. बड़े मियाँ, छोटे मियाँ सुभान अल्लाह.
So all the teams are ready? How's the Josh? How's the Josh? I can't hear the backbenchers. How's the Josh? Okay, so we have 5 teams today.
Yeah.
And let's see the intro video, number 3.
मस्त मलंग सोम मस्त मलंग जोम मस्त मलंग जोम.
Okay. So बड़े मियाँ, थोड़ा rules समझाएं. What are the rules?
Yeah.
How many teams we have today?
Today it's going to be a pure cricket league. We have 5 teams in this league. There will be 5 innings. Each inning will be a 4-over basis. The first over will be a pinch hitting over. That means the opening batsman, you can score up to 10 points, 10 runs from each over. The second and the third over will be a middle order consolidation, and the last over will be a slog over. Each over, a player can score up to 10 marks. So 40 marks for each team, being judged by 5 umpires. So in all you can score 200 runs. That's a decent score for a T20, isn't it?
Okay, okay.
So let's have a toss, Harshul.
Before that, let me tell them what all prizes we have today.
Yes.
So our judges will decide the best team, winner, runner-up team. Then our judges will decide the best scientific video winner, best scientific video runner-up, and our esteemed audience will decide the best entertainment video runner-up and winner. So we have a lot of prizes.
And mind you, we are not disappointing anybody.
Yes.
Like the first winner team, 4 trophies, runner-up team, 4 trophies, and all the remaining 3 teams will get participation trophies. How's that for Hyderabad?
And all audience will get some money in their account from treasurer.
Oh, though I am accountable. I am accountable.
Okay, so let's have a toss.
Bilkul.
That will
Come
go
on,
first.
as I said earlier, Hyderabad, because they are software people, they are always in a hurry. They want to fly out immediately after the thing.
Who?
The captain.
Hyderabad
Dr. Chitra, she wants to fly out. She has to be left at 11:40, right? So the remaining 4 captains, I invite all the 4 captains to take the toss. Shall we toss the
So we
coins
have
first?
Dr. Santosh Honawar from Karimnagar Warriors,
Dr. Arup,
Brahman
Dr. Rishi.
from Banjara Mavericks, Dr. Rishi from Warangal, Rudras, and Dr. Arup from
Raman.
Charminar Knights.
Charminar. So this is just a symbolic coin. I am keeping it in my pocket. Now let all the 4 captains pick up a chit.
So पहला match fixing हो गया.
पहला तो मैच फिक्सिंग कर दिए. Chitra, I expect some gift from you after you reach Coimbatore, right?
Yeah.
So now,
2,
5. So as per your numbers, you will be coming to play your innings, I should say.
Wait.
Yeah.
Note down. Who is number 2?
So I request all the umpires. Number 2 is Dr. Raman. So Banjara Mavericks will be number 2. Umpires. Hyderabad Giants will be 1. Banjara Mavericks will be 2. Who is number 3? Number 3. Captains.
Captains, be attentive. Who is number 3? Number 3. Okay, sir.
3 is Dr. Arup. Mark. Number 4. 4 is Banjara Karimnagar. 5 is Rishi Warangal. Okay, so this is going to be the team order, the order in which the teams play. So, okay, you have to rush. Just relax. I invite the captain of Hyderabad Giants to play the first over. Power play, pinch hitting, first over.
No, volume is not coming. Volume is not coming. Volume? Volume connected?
Yes, we are able to hear you.
So here we are friends, Hyderabad Giants. See, believe it, we have to win this cricket match. The India has to win. So all of you, please be with me, be with us, and let us win and get out. Look at the strength of my team. Amazing energy in us, and just look at our play power. There we are, we've got it all our sixers, all our fours. We are sure to win. India is sure to win. Hyderabad Giants are sure to win. Can you beat it? Look at the way we do it. Ball after ball. We are always winning. Look at the crowd. Look at the energy. Look at the vigor. And that's the vigor this team is going to provide to you in the next few minutes. So look at them all cheering. Don't you think already that we are on the winning spree, the way we are going? And now look at our fielding. Look at the way we catch the balls. There we are. And now just watch. This is the last or the second last. You know, you cannot allow them to win this time. We have to catch it. There, we've got it. This is Hyderabad Giants for you. We are sure to win, and you're all with me because this is about India, and India has to win, and we have won. So there we are, friends. Thank you.
I need one mic. I need.
We go on to our first speaker, Dr. Neha Dulakia, who we all know is an amazing surgeon, and she's going to show a complex moment. You have to allow the glitches of audio visual, please.
Each team has 15 minutes, 3 minutes each video, 1 minute for the introductory video, and 2 minutes for the layouts. After 15 minutes, there will be probably Okay. Chai pa time after some.
surgery on a complex patient, we have Dr. Praveen for you. On to you.
Very good morning all.
Don't worry.
Yeah, mine is a posterior polar cataract surprise.
18 minutes.
Audio, please.
So this was a posterior polar cataract with thick plaque. So the pitch is very damp. I thought the ball will not be coming onto the bat. So I was playing cautiously. So took all the measures to be taken academically in the posterior polar cataract. So controlled the rexis with the round rexis has come. And I request judges and the audience not to go with the makeup and the caps. So we are coming plain to you, please. And I am a debut, so you have to admit this also. So the hydrodelineation with round ring glow. Then phaco with not much rotation it's comfortably done without any rotation or any problem. Then the main hitch came with the epinucleus. So I thought this will be a really game changer. No, I will land in the soup, a big bouncer will be coming. So luckily the plaque separated from the posterior capsule. So successfully I could remove the epinucleus. And after removing the epinucleus, I could see the shining posterior capsule. I thought, okay, I am done. So I am going to win the cup. Then went with the bimanual aspiration. So this is like a classical step where we need to form the AC, fill up the AC with the visco before removing the phaco, which is a very important step, which I did. Then I went with the bimanual aspiration. This was uneventful. So I thought I crossed all the hurdles, then I am going for the final overs and I can win the cup. The match, then the cup. Then I went for the hydrophobic lens implantation. So I was about to close, just want to aspirate the visco. Then the hell of the thing happened. Then suddenly the lens was going down. I was really shocked. So oh God, what happened? Then immediately how the Surya Kumar Yadav got a catch in the final cup. The same way I hold the catch, a good catch, so that lens could drop and I hold it back. Then I removed it and then vitrectomy done, then followed with a 3-piece implantation, and then have a solid rexis margin all the around, and then completed the vitrectomy process also, then close the chamber with air. So thank you all.
Thank you, Dr. Praveen, and we have a very dynamic Dr. Charuta who is going to keep us all stunned with her presentation. On to you, Dr. Charuta.
Good afternoon, everyone. This is a young male who's complaining of severe photophobia. He couldn't sit in my OPD without that covering which he's showing. And the only way he could open his eyes was by closing his nose. On examination, he had a failed graft and recurrence of a gelatinous droplet-like keratopathy. I did for him a gelatinous keratolimbal allograft, where you can see the allografts over here, and 4 years later his surface is still stable. The graft failed and we did a desec, but the surface is still maintained without any recurrence of the gelatins. This is another young boy with xeroderma pigmentosa. We did his excision biopsy cryo with amniotic membrane full thickness keratoplasty and allogenic slet as prescribed. And yet after 4 years he had come back with interface haze and a failed graft in the left eye. So once again we ran the magic of KLAL, and now we have sustained outcomes since then. His visual acuity has now improved to 6/24 and 6/36 in both the eyes. Another case with severe vernal keratoconjunctivitis, presented with extensive limbal stem cell deficiency post keratolimbal allograft having sustained surface. So Richard Thoft has first described this procedure in 89-90. Modifications were done by Feister, by Jun Shimazaki, wherein the donor and the recipients, the shapes were altered. Edward Holland has described using whole globes. Kenneth Kenyon and Kempik also described eccentric KLALs. Sheffer-Seng described, Mark Manis described some modifications, wherein how he fixated how he fixed the globe in order to have ease of harvesting. Anthony Aldave used another technique, novel technique, where he used a PMMA sphere to keep the globe stable. Marjan Farheed again described another area of usage where she implanted multiple KLALs near the symblepharon. KLALs are indicated in bilateral LSCD where there is recurrent breakdown of epithelium and there are failed autologous transplants as we saw in the case of xeroderma. They give advantage of ocular surface stability in more than 72% of the cases. Coming to my case, this is the procedure that we followed in the gelatinous droplet keratopathy case. A large graft was done since the previous graft had failed. A donor tissue of appropriate quality was placed. The keratolimbal allografts were harvested using sharp scissors and lamellar dissection to create a very thin stromal bed, and the epithelium was retained. Finally, amniotic membrane was placed over it. This is another technique which I have used, wherein the globe was mounted on an artificial anterior chamber. Lamellar dissection technique was used using a sharp crescent blade, and the lamellar dissection was continued beyond the limbus. The lenticules, the cornea was then dismounted, and then the lenticules were carefully cut in the shape that was desired. So intelligence and capability are abound on this judging here. Judges are capable and intelligent. I want you to give you the opportunity of seeing something beautiful. Thank you very much.
Harshul, I think there was some bad light issues during their innings. So I think we keep them to make grace. I request the judges not to penalize them for the timeout. As a captain is always in a hurry, the captain is always in a hurry. When I was a child, I used to play gully cricket, The teams, they used to bat first and they used to run away. So the other teams, the other teams, they used to say, "Ye kya batting leke bhag ja rahe ho?" So खेलना है खेलो, नहीं खेलना है नको खेलो, मेरे बाप का क्या जा रहा. So I asked Chitra to translate in English. So she said, what she said, play, no play, no play. What my father goes. भागती है.
No, this is an audio.
2 minutes दे रहा हूँ ना इसीलिए.
I saw Rishi going there, and doing something with laptop.
No, let them talk in
Who
English.
Who can hijack Dr. Chitra, tell me?
इसीलिए I asked you to translate in English. You did very good job.
Susi, can you help in that?
Yeah. I'm always there to help. What?
This one.
They are trying both ends. Whichever end functions, she will be going to that end. One is Harshul Tak end, one is Manoj Mathur end.
Okay,
let's see.
Chitra ma'am. Chitra ma'am, it's all.
Volume hai? Yeah.
Ma'am, it's here.
It's there.
It's everywhere now.
Yes. Bhago. Otherwise, I'll run you out.
Come. So match will resume again. And sorry for delay because of rain.
Sorry for the interruption. There was a rain break.
Sorry for delay because of rain.
Yeah.
It's connected there?
Very nice.
Can I start? So, is it connected?
Yeah, connected.
Yeah, it's connected. So, dear friends, this was just rain, and this was some way to challenge us Indians from winning. But we are up for the game. Please just be with us. There's absolute commitment. Increase the volume. There's absolute commitment for Hyderabad Giants to win. There is no other way. We have a strong team here. It's just that we had to make the right as right and the wrong as right. But things were not going right. Things were just not going right. I thought it was a clear PC, but look, the lens is tilting into vitreous. Is it tilting into vitreous, or am I imagining it? But we had to win this match. And somehow it was unstable, and the best thing was this patient had to leave abroad. There was instability in the back. The ball had to get caught somehow. We couldn't lose this match. So I just somehow got it on the anterior chamber. a high myope, a deep anterior chamber. I had my own thought process acting, but we had to do a vitrectomy because whenever you're manipulating, and there it was all about stability. You know, we are intelligent. We know how to see that the ball comes back to our side just as I position the IOL back, and then very gently place the haptic in the sulcus. This is a deep anterior chamber and there is going to be no pigment dispersion. It was a toric IOL in a high myope. It was promised, it had to be done, and look at the player doing it, and that's how we are. Like, we cannot lose even in adverse situations, and we ensure a complete vitrectomy, remove all the viscoelastic, do an optic capture so that the pupil doesn't rub on the optic. The optic is in the capsular bag, the haptic, and we had to wait for the third umpire. But look, 3 months, it's absolutely bang on, 168-degree axis, 6/6 vision, and that's what we are. Is the decision pending? No decision is pending. We are just there, top class. You know, now we are in the dire states. We had to win this match, but this was a polar cataract. And you know what happens? I got that horizontal strip of PCR. I had to keep calm. We had to win this cricket match. World Cup had to be ours. We did a vitrectomy. There was space above and below. So we would place the lens in the bag. Do we place the lens in the bag? Look what is happening. That opponent is getting a sixer and he cannot get a sixer. They are not allowed to get more runs. So there I place the haptic, the optic in the capsular bag. I have done that, but I have to do something. I have to get this optic out. I cannot leave it there. There's a horizontal rip. Look at the catch, but just as he was catching, he loses his stability. But then we have that extra sense of dealing with emergencies as I'm dealing at this point of time. I get the optic out of the capsular bag, and this is what you call as a reverse optic capture. The first one was an optic capture, reverse optic capture. The lens IOL is absolutely bang on the axis. Absolutely clear, absolutely online. You know, absolutely. Just watch how the match is going on. You know, the ball could have got slipped, and there he had slipped. He had come to the side, but the ball was thrown and the other fielder caught it. And you know what it meant? It meant that the reverse optic capture is 167 degrees. It meant that the optic capture works. It meant that we won the match. So please, friends, let's get up and go. We have won the match. We have won the game. And there is no second thoughts about it.
Okay.
Thank you very much, dear friends.
Come on.
And most importantly, friends, thanks a lot for this wonderful 3-day stay.
Rishi Warangal.
Okay, thank you. Rishi, my friend, Chairman Scientific Committee, Telangana Ophthalmic Society. ये लोग का क्या करता? Tell me now.
नेहा जी बोलते हैं आज मैं ऊपर आसमान नीचे
Manoj. I think they should change their name to lens droppers.
Of course not. Of course not. You saw amazing matches.
बाउंड्री के अंदर आके कैच
Rishi,
पकड़
don't
रहे
you
हैं
think they are totally confused? One person is dropping the lens and removing it and putting a new lens, and the other person of the same team is putting the same lens. So what message do you want to give?
That we all are about economics. Chitra. How do you win the game?
Yes, Rakesh.
मैम पहले आप लेंस को अंदर पेटीएस में घुसेड़ देते फिर बाहर निकाल देते, ये क्या है? बाहर केवल कैच की प्रैक्टिस की और किसी की नहीं की, बैटिंग कौन करेगा? जीतने के लिए बैटिंग जरूरी होती है मैडम।
राकेश मुझे ऐसा लग रहा था कि बैट्समैन भी वही है, फील्डिंग भी वही कर रहे हैं।
अरे ऑलराउंडर्स हैं भाई।
डॉक्टर
समझ में नहीं आया
ये क्या हिट
टीम
विकेट
के
था
दो
क्या?
लोग हैं क्या?
It was a proper hit wicket, everything going fine, and then you have putting the lens in the vitreous. You need to be very careful when there. And Rishi, what is this slat here? Do you use slat or do you use?
हाँ, so that's what I want to tell Charuta. अब स्लेट है, तुम KLL क्यों कर रहे हो? मतलब बाबा आजम के जमाने का procedure, you don't need it. If you do it properly, it will work.
Okay, right. Perfect. Thank you so much, Team Hyderabad.
Thank you very much. I have to leave for the flight. Thanks a lot, Rishi. Thanks a lot, Telangana, for giving me this wonderful 3-day most enjoyable trip.
Thanks, Chitra.
Thank you.
High five for you. Well done.
Thank you so much.
Now we have a bit of time at our disposal because we have sent off the Hyderabad captain.
Yes.
So now let me introduce the panel of umpires to the audience. Right? We are going to select on science, and we are going to select on impact, entertainment value, and technical aspects of the videos that they present. To select the science aspect, Subhadra, Malika, Nandkishore, and Madhukar. And to select the overall impact, video quality, and the entertainment part, Dr. Vidya and Dr. Ravi Kumar and Dr. Badri Narayana are there to do this scoring. All the best to all the teams. Now we come to the next team led by Dr. Raman. Your introductory video, please. And I request all the panel of judges to give some weight to the introductory video also that they present. You can put some extra 1 star, like in the kindergarten, teachers put a star, no, golden star, silver star, something like that. You mark 1 star, 2 stars, 3 stars. That will help us if there is a tie.
So next team is Dr. Raman's team, Banjara Mavericks.
Yeah.
Interactive video. Intro.
Intro video.
Don't worry, we will give time
No,
for
sir,
this
no
because
worries, sir.
Harshal,
we
the
are
weather is
Banjaras,
quite
sir.
cloudy
Come, we
and
are
we are
Banjaras,
okay.
we are
Come on, play,
freestyle
play,
people.
play.
We are Banjaras, sir. We are freestyled. We don't care anything.
ಒಂದ್ಸಲ ನಿಕೋ ಹೊಡೆ ಸಿರಿಗೆಲ್ಲ ಕೋಡೆ ಎಲ್ಲ ಎಲ್ಲ ಕೋಡೆ
Wow! कितना क्रिस्टल क्लियर वीडियो था हर्षल.
Start. Now my case one. Yeah.
Play from that podium, please.
Yeah. पहले मेरा केस प्रेजेंट कर रहा हूँ. हम तो बंजारा मैवरिक्स है, फ्री स्टाइल पीपल. So I'll be showing some dancing eye and then the singing eye.
Play one.
सर बंजारा में कैप्टन ही सब कुछ होता है, कैप्टन ही बैटिंग करता है. फर्स्ट बैटिंग
तो
कब बंजारा ही होता है.
पहले बैटिंग मैं
बंजारा ही फेंकेगा.
लगान का आमिर खान. Let me present to you.
Oh, रोहित शर्मा. शुरू कर रहे. डालो ना मेरा. बोलो ना. सर प्लीज मेरा डाल दो. No.
Play from there, please.
No, बंजारास को थोड़ा फ्री टाइम देना पड़ता.
बारिश हो रही है यार.
No.
Tick 1. Come on, Ram.
नहीं. हो गया सर.
हाँ, बहुत ज़्यादा टाइम लिए तो फिर we will have to do something.
Yeah.
Come on, start.
Now I am showing a sinking eye in the right eye. So large ISO deviation.
15 मिनट बोले तो 18 का काउंट कर सकते.
Volume.
Right eye. As well, there is a secondary large ISO deviation in the left eye, occasionally seen. In this case is taken for right eye lateral rectus Y split without recession and medial rectus recession of 3 mm.
Here what
And the parents' main concern and the complaint was that there was an annoying downshoot whenever the child is looking to her left.
In between, can I see? The right eye was sinking occasionally whenever the child is seeing to her left. So, and the left eye was showing the secondary deviation most of the times. The vision was poor in the right eye, but though the right eye
maintaining the gap of about 10 mm.
Right eye, when right eye is fixing,
So the
left eye is
split
showing
ends of partial tendons
and
were
when patient
again
is seeing
switched
to the
back
left, right eye was
to the
sinking.
remnant of lateral rectus tendon. ISO deviation of 10 to 15 prism diopters. So in the post-op period,
Now
we achieved the orthotropia, and the downshoot is reduced significantly, and even the secondary deviation was not seen.
now we lifted up the eye.
This
The
is 3 months
sinking eye in the
post
right
picture,
eye.
quite satisfactory. Now we are presenting the second case, deviance retraction syndrome type 3 with hypertrophy with vertical retraction. And on preoperative motor evaluation, we can find here on primary position there is left eye showing an exo deviation with hypertrophy, exo of 40 prism diopters and hypertrophy of 25 prism diopters. There is abduction limitation in left eye is seen, and gross adduction limitation, and an attempted adduction. There is a gross offshoot in the left eye is noticed.
So you can see
this is
here
offshoot and
the
adduction.
dancing eye in the left eye.
Really annoying to the
Whenever the girl is looking to her right, the
this
left eye
retraction
is
and
just
the
dancing
adduction
and going
can
up and
notice
down.
from side pictures.
So you can notice here.
Post-operatively, there is a significant reduction of offshoot in the
So
left
the
eye and
dancing
adduction. But anyhow, the
is reduced.
hypertrophy was still remaining. So significant reduction of offshoot noted on adduction. And after 3 months, the left eye taken for second stage surgery, that is SR, recession of it. And hypertrophy reduced post-operatively. It's quite sad.
Yeah, in both cases.
As well, there is a secondary large ISO deviation in the left eye.
You can start.
Occasionally seen. In this
My
case,
vice
is taken
captain is
for
starting his innings.
right eye lateral lattice
batting.
split without recession and medial
Stop now,
lateral
stop
recession
now.
of 3 mm.
Stop that video.
आंख डांस कर रहे हैं रामन के इधर राकेश उधर साहिती वैसा he is depicted the eyeballs dancing, you know. One eye is Rakesh, one eye is Sahiti. They are just dancing.
Can start? Yeah. There is no music, background music is.
Good choreographer, Raman.
Yes, sir.
So we started the match, and this looked like a nice Australian pitch. It was fairly white and bald. So first of all, I had my 12th man coming in. There was a side port made. So this was a subluxated cataract, and as you can see, my 12th man went inside, did a little bit of posterior vitrectomy to clear the pitch for me. And now my main bowler starts. The batsman looks a little arrogant. It's tilting its stance, and my main bowler comes and fires a nice yorker. And now I get my fielders to come in. So this is the capsular tension ring, which now keeps the batsman in place. We have pushed the batsman back, and my fielders are fairly close in. So I have all slips in place ready, and this has nicely put the batsman in place. And now my spinner comes and starts dodging the batsman, and we are nicely trying to send him back to the pavilion. And now we put the Sionis CTR ring. I'm just trying to stabilize the bag here, and so that we find that the pitch is fairly bouncy. And now I have my spectators who are now running onto the pitch. So with a railroad technique, I now stabilize my capsular bag. So I'm now fixing the capsular bag to the sclera by making a knot, and I tie the Sionis ring and the bag to the sclera so as to make the bag stable. And now this batsman looks fairly in place, and now we are doing the last overs, wherein we just deliver the bouncer, and I send this team back to its pavilion. Now this looks like a black and brown West Indian pitch, fairly low bounce. So here I leave behind my intentions of doing a flax or a phaco, and I go for a small incision cataract surgery. So my spinner starts with the opening overs, and the spinner is nicely bowling its leg breaks and googlies. As you can see, the batsman is fairly stingy and stubborn, and so my bowlers are now trying to rotate the batsman up and down, change their stance, and trying to deliver the batsman, and now the batsman is out and he's going back to its pavilion. But now, as you can see, as the host team always cheats, I can see the ropes are now inside. So you can see a subluxated bag, the rope is coming in. They are now trying to shorten the dimensions of the ground. So we put the CTR ring and push the ropes back so as to create a level playing field. And then my fast bowler starts the demolition act. We put the lens in the bag, in the stabilized bag here. And finally our job is done and the team has completed its match. This is just shaving off the leftover grass on the pitch. And hence we send the team back to the pavilion. Thank you.
Hello, good morning everyone. Today we are representing Banjara Mavericks in TOSCON 2024. Patient had come very lazily after 5 years of his complaints, complaining of diminution of vision and deviation of the left eye since 5 years, and there's a positive history of consanguineous marriage of the parents. Sound? On examination, we thoroughly examined the patient and did all types of tests, and we found out that there is a left eye 30 degrees alternating exotropia with anterior segment left eye RAPD, and both eyes showed near vision of 636 and 912, color vision 617, and but on examination right eye also showed to be optic atrophy. Arey bhai, kya ho gaya? We didn't expect right eye optic atrophy. On MRI, there was a bilateral optic nerve thinning and also loss of volume involving extracorneal muscles with homocystinuria. And we did a visual field test of 30-2 with reliable perimetry that showed incongruous hemianopia. There's a dry field and there is no way we can treat this patient, but we kept on looking for the treatment. We thought, and then finally we got an idea of what to do with the patient. We just tried. There's a orthoptic treatment which is done in case of amblyopia patient, but still we wanted to try as we have that management, and then we started with the therapy of the patient. Orthoptic is a 3 loads of LED series with centrally containing green light and peripheral red light. And also we started on tablet citicoline and homin. It basically activates magnocellular and parietal cortex, finally activating lateral occipital cortex. We have found a hope in this patient. We have finally, in a dry sand sea, we have got a rain. Vision has improved from 636 to 618 parts in right eye and 624 parts in left eye with near vision improvement, and there's also contrast sensitivity and stereo acuity improvement in this patient. The sunset didn't sunset, it actually raised. And finally, my happy moment is always dancing, and I was dancing. Thank you, Team Banjara Mavericks. Thank you.
Come, Rakesh. कोई नहीं डरता जब तक बीवी सामने नहीं है। जब तक सामने नहीं है कोई नहीं डरता बाबा।
राकेश, ये तेरा टाइम काउंट हो रहा है।
प्लीज गिव द वॉल्यूम।
हेलो, आर यू डॉक्टर शाक्या मिसिस स्पीकिंग? टॉकिंग इंग्लिश? अब देखो,
हमारे एक वो थे, क्या नाम उसके वाइफ के रिलेटिव आया कि बोले कि ओपीडी में दिखाना है। मेरी वाइफ बोली कि उसको ठीक करो, नहीं मार मार के भूत बना दूंगी।
लेकिन एक सेकंड।
And then I saw the case, there is no lens in the antechamber and posterior chamber. Then I saw there the globular mass in the supranasal quadrant. I saw and then मैं तो बॉल्डी हो गया. Then I took the case very, मतलब मैंने अपनी हिम्मत करके केस तो ले लिया।
तुम चल रहे हो बेटा,
एक दिन पूरी तरह फंसोगे। उस दिन मुझे याद करना, मैं पहुंच जाऊंगा।
ठीक है बापूजी, मैं कोशिश करता हूँ, बीवी का डर है। देन आई कट द कंजक्टिवा एंड रिमूव द लेंस फ्रॉम द कंजक्टिवल स्पेस एंड इरिगेटेड प्रॉपरली। And remove the blood clot from the antechamber, and then do the vitrectomy, and then मैंने stitch the tear part, and मैंने बोरे की तरह सिला था इसको
सुतली से।
बट आफ्टर कंप्लीटिंग द केस विजन नहीं आया, और वो देखो हमारी बीवी ने क्या हालत की, आप खुद ही देख लो।
देखा आपने लापरवाही का नतीजा है।
गजब बेइज्जती है।
लेकिन आई टुक द केस अगेन। आप हिम्मत तो देखिए।
राजा जी अपनी शक्तियों का पूरा इस्तेमाल कर रहे हो, लेकिन लौंडा यहाँ नहीं।
Then I cut the conjunctiva, make the scleral flap 3/4 and bisect the cornea, mark it properly on the both side and 1.5 away from the limbus, and just mark it again under the scleral flap and do the Agarwal glue dye technique, and then make a scleral tunnel for the haptics, and then irrigating and put the SFI। यहाँ भी SFI अल्टा पल्टी हो गया, मैं फंस गया था पूरी तरह। 1.5 घंटा लगा इसको सीधा करने में। Then finally I did, and then properly place the haptic under the scleral tunnel, and then put the glue over the under the flap. And then I feel like that vision was 6/9, जैसे वही फीलिंग हुई थी जो रविंद्र जडेजा को हुई थी। मेरी वाइफ ने आके पैर छुए, जो वही फीलिंग हुई थी जो रविंद्र जडेजा को हुई थी। थैंक यू सो मच।
इंग्लिश अब देखो।
so much. Finally we won the match.
Okay, okay, Arup
The help
sir.
of my vice captain Rakesh
Arup
and
sir.
Varun and Sahibi.
आपको नहीं लगता राकेश की बीवी ठीक मारती है उसको?
I think so. I mean, Rakesh deserves it, but let me come to the point. You know, the best part of their show was the Sahiti Shakya Jugalbandi. I think that 2 minutes.
Was it a diversionary tactic, Arup?
I think so. You know, but they knew that nothing eventful was supposed to come, so they distracted the audience attention. And then I was wondering whether it's an ophthalmic Premier League or orbital Premier League. We saw 2 orbit cases, you know, and then I wanted to know what is the ENT equivalent of diplopia. Sir surgery was Dr. Raman surgery was going on. The 2 narrations were coming, and we really did not know what was the idea. Like, you know, it went over our head. And then, you know, Dr. Varun, your black cataract video, I would say that you have missed the game. You have lost it because yesterday Dr. Neha showed how to do a black cataract very successfully with a multifocal intraocular lens. So no further comments. And finally, Dr. Rakesh, so you refer to Dr. Agarwal, Amarda, he will not be happy with your performance because you did multiple sittings. He does, you know, everything on the same sitting, and his eyewears go in very smoothly, they don't get tumbled, you know, so I think you have a long way to go.
Okay, thank you so much.
इतने टाइम में राकेश 50 कैटरैक्ट कर सकता था।
बट वो बीवी का डर था ना, इसलिए नहीं हो पाया।
आखिर में एक बात सच्ची बताना, एक बात सही बताना, बीवी से बुके मिला
नहीं,
एट द एंड?
नहीं, खाना तो मिल गया कम से कम।
अच्छा चल,
वो भी गरम।
बेल।
Okay, next we have team of Dr. Arup. Are you ready? You're gonna go that side?
पूछो यहाँ इल्ले फिकर आजा इधर बीच पे लगा ले तू ठुमका 1 2 3 4 get on the dance floor 1 2 3 4 get on the dance floor booty shake come on the rock shoulder hit the party hit gimme some more 1 2 3 4 get on the dance floor booty shake come on the rock shoulder hit the party hit gimme some more
Mild showers again. Empire stop play for the moment.
Okay,
Harshal.
they are here.
Oh,
It's come, sir.
resume, play.
Yes. So this is a case of yeah, its audio is there, but I can speak if audio is not coming. I'll speak, no problem. So it's a case of a 63-year-old female. It was a case of abandoned SICS. As you can see, while doing SICS, the primary surgeon mistook the DM as the anterior capsule and punctured it, and the anterior capsule below it was also open. So they have sent to us to manage this case further. Yeah, go ahead. Yeah. So this is how it looked on slit lamp, and ASOCT you can see the DM that has torn. So we stained the DM with trypan blue and identify the area where the puncture was done. We took so there you can identify area of DM loss with the capsular opening. We took the use of an external illumination, and this scrubbiness assisted us to whenever we required this illumination at the limbus. So the capsular opening that was already there, we completed that and did a regular opening, and then we did a phaco in that area where the DM was already lost. And we did a controlled phaco and used the bare DM area to complete the phaco. These were the parameters that we used. And while doing this, we took care that the DM that was already there did not come in contact with the phaco probe. So only that particular quadrant was used to complete the phaco by using the flapper chip and flip technique. The nucleus was already soggy because it had a capsular opening, so we could finish off the phaco, and cortex aspiration was completed. IOL was also implanted.
Take it out and keep it there in front of stage.
And once IOL was there, visco was washed, and then again we tried to identify the area of DM loss, stained it again, and then did the final tamponade. A few venting incision was there to milk off any visco that was there in the interface. So that was the final post-op after 6 weeks. We could reattach the DM again and give the patient good vision with glasses. Thank you for your attention. Despite bad weather, we could complete the match.
Madhu, very wonderful performance. I think this is the best case I've seen so far in the day. I mean, I hope the judges will make a note of that. Congratulations for your show.
Good morning, Telangana. Thank you, a wonderful opportunity ichinanduku. It has been a brilliant meeting. Congratulations again.
Hi all. Sometimes a routine case can throw a googly at our confidence. A post-operative surprise at the slit lamp on day 1 after an uneventful penetrating keratoplasty. Patient had long-standing pseudophakic bullous keratopathy with scar. Post-operatively, a membrane was seen behind the graft along with vitreous in the anterior chamber behind this membrane. Now, is this a detached DM from the graft or is it a retained DM? An anterior segment OCT helps in correct diagnosis. The graft seems to have a hyperreflective DM of its own with a relatively normal pachymetry. A taut and thick membrane behind is suggestive of a long-standing DM detachment, unlike a fresh detachment. It was decided to remove this retained DM as there was vitreous in the AC and patient had suboptimal vision. Under the microscope, it is often difficult to delineate these layers. An endo-illuminating light pipe comes very handy when kept at the limbus. Here we see a window, in this case, in the retained DM. Trypan glue injected into the AC through a paracentesis starts to seep into this interface between the two DMs. A dispersive viscoelastic is then injected into this window to protect the graft endothelium. A cyclodialysis spatula is then swept behind the retained DM, releasing the adhesions between the iris and retained DM. Bimanual anterior vitrectomy was performed after this in the anterior chamber, clearing the vitreous. An attempt was made to eat up the host DM with the cutter, but this didn't work, so a microscissors was used to cut the host DM into quadrants, which were then easily removed with the vitrectomy cutter. After ensuring that the AC was clear, the paracentesis was sutured. Post-operatively, the graft maintained clarity with a deep anterior chamber and better view of the fundus and improved vision from finger counting pre-operatively to a 6/18 post-operatively. An ASOCT pre-operatively would have probably prevented this surprise. It is important to differentiate between retained DM and detached DM as the management is different. Retained DM is known to be seen as a taut retrocorneal membrane if it is long-standing, as opposed to a freshly detached DM which is known to be undulating. Although observing this condition or DM clearance in the visual axis with Nd:YAG laser have been alternative approaches in literature in managing these cases, it is known that this condition hastens endothelial loss post-PK. An endo-illuminator pipe comes very handy to tackle such cases. Thank you.
Thank you.
Hi all. Sometimes a routine...
Wonderful show, Suchi. She is not only a talented, artist, a talented musician, but you saw the work that she does. Wonderful science. So we have the next one, Dr. Dikshit.
Thank you. I am here to narrate the story of a female who had a complicated cataract surgery elsewhere and presented to us with a IOP of 38 on 5 medications and a vision of 20/80, and the reason for the problem was a single piece hydrophobic intraocular lens in the sulcus. The pigments at the edge of the optic that you see is a sign that confirms our diagnosis, and the vitreous was coming through zonular dialysis where the surgeon had not performed a vitrectomy. So our challenge was to take out this lens, and the vitrectomy was performed to take out this stubborn vitreous strand. And once that was done, the culprit IOL was prolapsed into the anterior chamber. This was not difficult as the intraocular lens was in the sulcus already, but we coated the endothelium with viscoelastic. But do remember, the posterior capsule is already challenged, and we don't want to get hurt where it hurts the most. We have to protect the posterior capsule. So even before we do anything to the single piece lens, a 3-piece lens was placed behind the single piece lens to protect the posterior capsule so that the further maneuvers could be carried out safely. Now typically you would want to extend this incision or use a scissors, but all these techniques which have been traditionally used, they are a challenge to the endothelium, including the twist and out technique. So we went to this cartridge pull-through technique, and the problem that we had was the cartridge that is available with us, it's not short enough. So we used a late cut technique, heated a 11 number blade, cut a B cartridge from Alcon, and used that to introduce into the eye the Grishaber forceps. A Pachman forceps can also be used, and you cannot believe that this technique has changed the way you can easily perform an IOL exchange. The IOL can be extracted through a 3 millimeter incision. And what did we do for glaucoma? Minimally invasive again. So we used a cheap 24 gauge needle to rip off around 4 clock hours of the trabecular meshwork. And that is how we tackled both the intraocular lens exchange and the glaucoma in a minimally invasive way. Of course, do not forget to wash off the viscoelastic gear. Actually, the glaucoma surgeons. So at the end of it, we are victorious with an intraocular pressure of 13 millimeters on 2 medications. And if everything can be minimally invasive, there's no reason to take pressure. Just chill.
Wonderful, Dr. Dikshit. Such a wise surgical decision, skillful tissue handling, and a lot of innovation out there. So very well done. So I go to the last case now. It is the story of the guest who stayed too long. A wise guest or a good guest doesn't overstay. You know, Rohit and Virat left in the right time. Earlier, Dhoni left in the right time. I'm not on the screen. So can you bring me on the screen? Yeah. Anyway, so basically, we saw Virat and Kohli, Virat and Rohit leave at the right time. Earlier, Dhoni left, quit cricket at the right time, and my childhood hero Sunil Gavaskar. So basically, a guest should not overstay. Now, this was a patient who stepped into my clinic, was referred to my clinic, and if you see the pupillary ring there, BX ring, this patient has been phakic for a couple of months, more than 2 to 3 months, with the BX ring in the eye. And phakic, there's a large scleral incision, tunnel incision, there's a peripheral antisynechia, so, and the cornea was not in a very good shape. So let us see what we did. So the plan basically was to expand the BX ring. So I was sitting superiorly because the tunnel was a big superior tunnel. Temporarily there was a lot of peripheral antisynechia. So I was quite convinced that I will not be able to take out the BX ring through the temporal paracentesis, which you are accustomed to. So I injected viscose into the anterior chamber to protect the corneal endothelium to form the anterior chamber, to have a deep anterior chamber, and then created an inferior paracentesis. And so that gave me a direct access to the BX ring. And it is such a wonderful ring. It is a ring which is very easy to place. A ring which, as you see here, it is very easy to take out of the eye without damaging the tissue structures. Now, you know, the anterior chamber, of course, was not angle was not healthy, so there's no question of putting an anterior chamber lens. So we did what is the best solution for this patient. 2 sclerotomy needs incisions on either side, diametrically apart. 7 Gore-Tex, we have stopped using proline, ninoproline, we have stopped using it. So basically we used a scleral fixated rigid IOL. It is a 6.5 millimeter optic, 14 millimeter in overall diameter with 2 eyelets for fixation for the sutures. And then each suture is now threaded through the eyelet, as you see here. And then it is again brought out. So this is a Gore-Tex suture, and the needle that comes with the Gore-Tex suture, it is very difficult to penetrate the sclera. So we usually detach the sutures, and you know, this is the way we pass. So in effect, this is actually 4-point fixation of a rigid scleral fixated intraocular lens. And the sutures at times can be pretty bulky. So what I do here is using the Gore-Tex needle itself, you know, pass this needle from one sclerotomy side to the other sclerotomy side, and so that way the suture gets very well stabilized. I'll be using just a single throw here, and that also is very easy to bury within the substance of the sclera. And this is the end result. The conjunctiva is closed with white nail suture. Post-operatively, this is I think about 10 days down the line. She has a vision about 6/18 right now. There's a little bit of cylinder from the scleral tunnel. Patient has been doing well. Thank you very much for your attention.
अरविंद, या खत्म वक्त से पहले माइक प्लीज क्या है शुड द एम्पायर से 6 or 4
hit wicket. The only good thing about these Charminar nights is their introductory video, nothing else. Number 1, they all are endothelia anemia. एक बार में पेशेंट ठीक ही नहीं होता, दोबारा ओटी लेके जाते. सारा पेशेंट सेकेंड टाइम ओटी, ये प्रॉब्लम है.
Your patients have been referred to us.
It's your time. Your time. उनकी बैटिंग हो गई.
So completely hate wicket, isn't it? और एंडोथीलिया के इतना पास जाके ऑपरेट हो रहा है, 2 लेंस जा रहे हैं, इतना जगह ही नहीं है. No place for 2 IOLs. So causing so much trauma to the endothelia. So your team is endothelia enemy.
T20 मैच में 2-2 इनिंग चाहिए. How friendly your team is to endothelium. Next is team of Dr. Santosh Honawar. पहली टीम का वो स्पिल ओवर टाइम है. No.
Volume.
Yeah, it's playing. Play. Just a minute. It's not good. Full screen mode. Covers have coming back. Play will resume soon. डरने का नहीं. ये अरुण कुछ तो बोलता रहता है बीच में.
यार इतना क्या टाइम लगा रहे हो तुम पैड्स पहनने में यार और हेलमेट पहनने में? टेकिंग टू मच ऑफ टाइम है.
No, वो लेग गार्ड पहनने में टाइम लगता है एक्चुअली. The way the leg guards were invented a century before the helmet, I believe.
The team should be disqualified. There was a Bangladesh captain who appealed because of the late arrival of the batsman, and he was given out.
It timed out.
Yeah.
But बारिश पड़ रही है यार, हम क्या करें? Okay. So we have Charminar Warriors. Karimnagar Warriors.
Yeah. Karimnagar Warriors, we have Abhinasha Maharani, Arvind Kumar Mourya, Vice Captain, and Vineet Joshi. We'll start with Arvind Kumar Mourya. He'll show you a very innovative technique.
So be prepared for an adventure of your lifetime. It's just a beginning. So this PBK and Fuchs dystrophy, they are a nemesis for the endothelia and they require DSEC and DMEC, and there is acute shortage of the corneal donor tissue. Khatam. Bye-bye. So this is to change the perception of these corneal surgeons that it is not available. 3 crazy ophthalmologists, they decided to go ahead with the chemical endokeratoplasty. Endothelia, it is a non-regenerative monolayer of neuroectodermal origin that maintains the dehydration and transparency, and minimum 700 to 1000 is required. So there is a stop switch for the mitotic neuronal activity, and that enzyme is Rho kinase. So it stops the mitosis of these neuronal cells after some time. So we developed this new ROC inhibitor topical drug. It can induce controlled and stoppable exponential mitotic cell division in the corneal endothelial cell. So this was a severe case of PBK, you can see, and only 300 cells were left. Only 300 against the million. So the onus was on the 300 cells. So we started this eye drop on the 55th day. You can see the clear cornea, vision improved, best corrected 6/9, and 1200 was the CEC count. You can see the nucleus also. This is Dr. Rishi. And we also treated Fuchs endothelial dystrophy. You can see the bully and the gutata. They are no more after the treatment. It's a slit lump examination. Now you can see 738, the count increased to 1072. And you can see the nucleus also. AS osity also improved. You can see there are no gutata or bully after day 40.
Oh my God!
Patient is so happy. No photophobia, vision improved. So rock eye drops controlled mitotic cell division in human corneal endothelium in vivo, and they will be the future of the DSAC and DMAC in the near future. So we have done this because there is exponential growth of this mitotic activity, because now the mother as well as the daughter cells, they are dividing. And once we stop the eye drop, so it stops there. There is no extra growth or like the cancerous growth is seen with this eye drop, and it will be available by 2026 hopefully. So say bye bye to DSAC and DMAC.
क्या सीन है?
Thank you, Arvind, for a wonderful innovation.
अरविंद, मुझे ये समझ में नहीं आया, पहले फटाक क्यों मार रहे थे बॉनेट को? शुरू करने से ही हार मान रहे थे क्या?
Abhilasha is next and she...
सर वो आइडियाज लाने के लिए सर मार रहे थे सर, क्या आइडियाज आए? फ्रेश आइडियाज.
She presents a case of retinitis.
Volume. Steroids are all used in the treatment of uveitis with good initial success. But sometimes this success... I'll play it again. Steroids are often used in the treatment of uveitis with good initial success. But sometimes this success may be short-lived, just like this India-Pakistan match, where this last run-out resulted in a tied match, followed by a bowl-out.
The match ends in a tie. What a finish to an India-Pakistan game.
Epidemic retinitis is acute onset multifocal retinitis following a flu-like prodrome. Rickettsiosis is an important cause and it is often treated with steroids as initial empirical treatment. But because it is an infectious disease, we studied the flow deficit in the superficial capillary plexus following resolution of retinitis using swept source Octa with ImageJ software. We compared macular ischemia with doxycycline or steroids as the initial treatment. Retrospective analysis of medical records from October 2017 to April 2021 was done. Diagnosis was based on presence of retinitis, history of high-grade fever and a positive Weil-Felix test. 17 eyes of 11 patients were included. 11 eyes were treatment naive and belonged to doxycycline group or group 1. 6 patients had already received local or oral steroids and belonged to the steroid group or group 2. All patients were treated with doxycycline 100 mg BD. Best corrected visual acuity, central foveal thickness and percentage area of ischemia on Octa was calculated using the ImageJ software. The image was selected, converted into 8-bit, threshold function was applied and percentage area of ischemia was obtained. Now results time. The doxycycline group, there was significant improvement in visual acuity. The visual acuity improvement was not significant in the steroid group. Central foveal thickness improved significantly in the doxycycline group. This improvement was not significant in the steroid group. Disappointment here for steroids. The doxycycline group now takes a significant lead. Coming to ischemia, The steroid group showed 3.5 times more retinal ischemia compared to the doxycycline group. And doxycycline group wins the match.
एकदम इन्होंने वक्त बदल दिया, जज्बात बदल दिए, जिंदगी बदल दी.
Conclusion: steroids should not be instituted in cases of epidemic retinitis. Doxycycline results in far lesser ischemia, better visual prognosis, and quicker recovery than initial treatment with steroids alone. Thank you.
Thank you very much, Abhilasha. Vineet, the Tech Whiz Kit, comes with an AI presentation.
I know everyone is presenting surgeries, so I'm going to do something different, and I'm going to show what we have tried to do. Can anyone load my slides? So we know imaging, how important it is, and what it's okay, will come. We know imaging, how important it is, and so in this case we know that in smartphone imaging our phones are not good enough to capture good quality images. So what we did was that we identified the problems of patients that are actually having in capturing these images, and we were able to then focus on developing a simple device for the patients which they could mount on any smartphone and then capture it using a very simple app which identified the problems of focusing and zoom and illumination. It gave a very simple and clear photograph of the eye with just one tap, which was uploaded on the cloud. So what we did was we trained the patients in our training area, and we trained the attenders to actually capture these images from home in a nice goody little bag, and then we had a teleconsulting who used to call them back in the back end to remind them on the teleconsult day to capture good photos. Initially there were hiccups, we got photos like this, so it was not very helpful, but as and when the patients use their own phones, the images started to improve like this, so we were able to follow up many of our patients in this way. This is one of my favorite patients. He sends me selfies from home looking in the mirror, and I could even diagnose that he's developed a cataract after a graft, and it's very easy to manage this patient. We locally check the IOP and we are able to see that the graft is doing well, sutures are fine. We can detect rejections in time and call them. Many of these patients are in Jammu, Kashmir and in Uttar Pradesh. They come for follow-ups. Infection monitoring is so easy, and I will tell you that one of the patient messaged me, that's the WhatsApp chat, डॉक्टर जी आँखिया में कुछ तो सफ़ेद सफ़ेद दिख रहा. मैंने बोला इन्फेक्शन है भाई, इधर आ जा, बहुत हो गया. So it's very simple. Similarly, one patient from Kolkata, we diagnosed recurrence of microsporidial keratitis and saved worsening in time and took her for transplantation. Truly effective. So far what we have done is, even in glaucoma patients, you can actually manage post-operatively and check for the health of the trab with this simple device. With the help of Cognizant Foundation, we have now distributed to 5,500 patients across India and conducted 4,000 teleconsults. And the best part is, it's eco-friendly. So per visit, we have saved 4,300 rupees per patient, and that's the carbon fiber that has been saved. Now let's talk about what we did with these images. Now we have a huge cloud of 10,000 images of eyes captured from mobile phones. So we developed an AI tool which can automatically detect the quality of images. Next, we auto-annotated the features of the graft and the features of the infections. And now we are trying to develop and pull it into a comprehensive chatbot that can solve all patients' queries. The interesting part is they can ask anything, they will answer the questions related to that. Best part is, you ask in any language, put it in English or Hindi, Marathi, it will be able to identify it because this is powered by ChatGPT. And then comes the risk stratification model, where it can identify symptoms, risks, and even identify the quality of image, and with pin code tell you which is the nearest center to go to. So that's all. Thank you very much.
Now I present to you our cool and calm Captain Cool, Dr. Honawat.
How much time it will take to the airport? My boarding is at 3:45. I'm saved, no? Absolutely. 2.5 hours from here. Like 40 minutes.
IT people?
Huh?
40 minutes. IT people, please.
Okay, that's
okay.
If your car is ready, 40 minutes. 18 minutes. Sunday, no? DC yatra hai, so it's
sound please. We have had a lot of cataracts since morning and a lot of OPL videos are based on cataracts. Volume please. Volume please, higher. This was a young lady with a medial dermoid, internal angular dermoid, adherent to the periosteum, where we make a direct approach right on top of the lesion, not holding it, but holding tissues around it. We dissect it free.
दिल है मुश्किल जीना यहाँ जरा हट के जरा बच के ये है बम्बे मेरी जान हो ही हा
This was a dumbbell dermoid on both the sides of the orbit.
जीना यहाँ जरा हट के जरा बच के ये है बम्बे मेरी जान
That was subperiosteal dissection.
कहीं बिल्डिंग कहीं ट्राम में कहीं
बाबा रे बाबा वो तो बहुत चांगला बहुत अच्छा
Open Gangnam Style. Gangnam Style.
This was a large dermoid.
Open Gangnam Style.
Then we bring in the cryo for assistance.
Open Gangnam Style. Hey, sexy lady. Open Gangnam Style.
कभी कभी लगता है कि अपन ही भगवान है
This was a much larger one, with a lot of fluid within it, thin-walled as well. So dissection in such situation has to be very careful under microscopic control. Dissection of the periosteal base, freeing it from the suture. Before we transeliminate to see if there is any extension and then very carefully remove it off the suture line.
डॉक्टर साहब चेहरे पर एक भी ऑपरेशन का दाग नहीं आना चाहिए.
There are some patients who don't want an incision scar on their face at all. For them we have sclerotherapy. We aspirate the contents of the dermoid, then we foam sodium tetradecyl acetate. That is the foaming going on. A small quantity of the drug is foamed and injected right within the lesion. Thank you so much.
Mic please. Okay, so that was team Karimnagar. ऋषि जी क्या बोल रहे हैं मौर्य जी? बात खत्म, डिसैक खत्म, डीमैक खत्म, काट रहे हैं हिंसा हिंसा हिंसा, सत्य 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 नॉट असत्य.
ये किनोशिटा ये ड्रॉप लास्ट 2 डेकेड से बना रहे, अभी तक तो आए नहीं. अभी वेट करेंगे और कितने साल लगेगा.
बट वो डॉक्टर मौर्य नहीं थे, ये बना चुके हैं. क्यों डॉक्टर मौर्य?
Yes, the patient I shown you, yes, already those were the real patients.
Yes.
Yeah.
Yes. Anything to say, Dr. Arun?
मेरे को भी अभी तक समझ में नहीं आया कि ये सर क्यों बैंग कर रहे थे, खटाखट खटाखट खटाखट, अब जब उस पे कार के ऊपर सर क्यों बैंग कर रहे थे यार?
Yes, चारुता?
50 डेज में नहीं बोल सकते हैं कि रॉक इनहिबिटर काम कर रहा है या स्पॉन्टेनियसली रिजॉल्व हो रहा है.
It was 55 day, exact 55 day.
Okay. No rebuttal. Okay, right. So now next we have the last team of today's OPL, Warangal Rudras. And let's see how Rudra they are. Huh? Rishi, led by Dr. Rishi.
Unfortunately, our captain had to leave at the last minute because of some reason. So we are going to have to. I'm going to have to fill in as the captain, and I will play his recorded presentation.
Right.
So that's our intro video. We are here to win. Volume, boss. India has won the World Cup, and that's what we're going to do today. We're going to win the OPL Cup today. We are the Warangal Rudras. We have 4 stalwarts in our team. Dr. Arun Kshetrapal, Gaurav Luthra, Dr. Ramesh Shah, and myself. And we're going to enthrall you and hopefully win the cup today. Just like India did for the T20 World Cup just a few days ago. That's how we're going to hold that coveted trophy very soon. Our first opening batsman is Dr. Arun Kshetrapal, and he'll share some of his very interesting cases.
Thank you, Skipper. I'll be showing you a case of PHPV in this 5 months old baby. As you know, in this, both the anterior and the posterior capsules were fused. It was very difficult to get in capsular opening, but somehow we managed to get a capsular opening, and the anterior capsule was very, very thick. That had to be managed with the help of forceps. Here I am using Haldipurkar's forceps to hold the anterior capsule, and I am trying to make a circular fashion opening in the anterior capsule. So the teaching is that whenever you encounter fibrosis, you don't have to pull onto it. You need to cut the fibrosis and use a bimanual technique wherein you stretch the capsule with one hand and cut it with the other hand with a micro incision scissors. And as it was cut, one of the blood vessels which was traversing from the iris to the anterior capsule got cut, and the iris got trapped into the forceps and it started prolapsing out. So there was a double trouble. The iris was prolapsing out and there was a bleeding. So what we decided that, following the scientific principles, we closed the main port with the help of 10-0 nylon, and then we cauterized all the blood vessels which were traversing the thick posterior capsule and the iris to get a bloodless field, to get a proper hemostasis. Now this posterior capsule was very, very thick and fibrous, which cannot be opened up with anything but the MVR blade. So we used MVR blade to make an opening into the posterior thick fibrous capsule, and then again used scissors to enlarge this opening, and again using a bimanual technique to complete my removal of the thick posterior capsule. But this much opening was not sufficient, and there was this tag which was later cut on with micro incision scissors. So this opening was not sufficient. There was still thick posterior capsule in the pupillary area, so we decided to make the opening larger. So this need to be attacked from various angles, from various directions to get a proper opening. And once we were able to make an opening, we went on to did anterior vitrectomy. Vitrectomy was carried out, and once the vitrectomy was over, we filled it with anterior chamber, and we made sure that all the ports were closed with suture, and that was the end of the case. Thank you very much.
That was a fabulous demonstration of how to keep your cool and manage a complicated case like a PHPV. Thank you, Dr. Arun Kshetrapal. We'll move on to the second presentation, my colleague Dr. Ramesh Shah from Bombay, and he has something very interesting to share.
Hello friends and colleagues, we are happy to introduce OmniFlow. OmniFlow is unique, novel, small and best glaucoma drainage device to drain aqueous from AC to retrobulbar space. A microvalve tube pressure regulator is fitted inside the soft silicone tube, which controls the outflow of aqueous humor, which will prevent hypotony and maintain IOP between 10 and 24/7 without or with minimum number of anti-glaucoma medications. This is how OmniFlow tube look. This is an anterior chamber end. This is a retrobulbar end, where a tiny Teflon pressure regulator is fitted inside the tube.
After putting L cut in the conjunctiva and after a little blunt dissection, insert a vectis to reach the retrobulbar space, which is very easy. Now we make one scleral tunnel, which is made by angled MVR 20 gauge, 7 mm away from the limbus at 45-degree angle. The tunnel is now lubricated with viscomethyl. The beveled end of OmniFlow is now inserted in and passed through the scleral tunnel. 3/4 length of the tube is pulled out. The valved end of the OmniFlow tube is inserted into the retrobulbar space. It goes quite easily as if a rope is falling into the valve. Second scleral tunnel is made, which is radial or perpendicular to the limbus, about 2 to 2.5 millimeters from behind the limbus, which is then entered into the anterior chamber, bisecting the angle between the endothelium and the iris. The beveled end of the tube is now inserted into the anterior chamber via the second scleral tunnel. Only the bevel goes into the anterior chamber about 1 millimeter or 2, maximum 2 millimeters. Then the excess bend of the tube is pulled back by vigorous pull, push and sideward movements. And as we can notice here, no matter how much we nudge, the tube will not budge. The tube cannot be pulled out unless we want to pull it out.
With OmniFlow, IOP is down from 60, 80 to 10 to 12 as soon as the tube is in. The microvalve regulates the IOP, keeping always about 10 mm of mercury. Gives excellent results in all severe, intractable, bloody and oily open-angle glaucomas. It is quick surgery and very easy to learn and master.
OmniFlow Supra is a suprachoroidal tube shunt for BEGS, BAGS, that is blab-free ab externo glaucoma surgery. With the OmniFlow tube grasping forceps, we now insert the tube in the tunnel and enter it into anterior chamber only about 1 millimeter inside. And as soon as the tube is in, IOP will come down. Please notice the controlled release and slow flow of aqueous humor. After cutting out the excess length, we can now insert the rear end of the tube into the suprachoroidal space. Please don't worry at all. This is very easy and a completely atraumatic step. Tube goes in as easily as a candle in cake. We can safely move the tube little back and forth to adjust the length.
Thank you so much.
That was amazing. What a lovely innovation. And right here, made in India. Thank you. The next one, volume is head. So this was a difficult case that stumped me once in the OPD. And this was a patient who had done a multifocal lens for many years ago, and somebody hit her with a lemon, and because of that the lens subluxated.
गया
And I was like, oh my god, अब क्या होगा?
ठीक ही हो जाता है और अगर ठीक ना हो पिक्चर अभी बाकी है मेरे दोस्त पिक्चर अभी बाकी
So I decided that I wanted to kind of try and refixate the bag, but the challenge was that it was a very old surgery and I wasn't sure I'll be able to put a ring inside this bag. So I inflated the bag with viscoelastic, and then I noticed that there's quite a bit of fibrosis, but I managed to get an opening. So I decided to fixate the bag with a Sioni segment. So we did these Hoffman pockets, which we know are very useful in any sort of fixation that one wants to do, including serial fixation. So that's the Sioni segment. It has that little eyelet. So we threaded 90 proline suture through this. One could also use other sutures like Gore-Tex. And basically ab externo technique. And we are doing a shake hand just like Kajol and Shah Rukh Khan did in DDLJ. And at the critical moment, he caught a hand and pulled her in. So just like that, we managed to pull the suture in and fixate with a double arm proline needle. So 2-point fixation was done, as you can see. And then we are inserting the Sioni segment, which is comfortably placed inside the bag. and then the eyelet, which has already been threaded, is then kind of tightened and pulled using the Prolene sutures, and the lens is now somewhat better centered. We pull out these sutures through the loops of the suture through the Hoffman pocket, and basically we open this thread and then just tie it under the pocket so that none of the knot is exposed out. So it's actually very elegant, useful technique to use these Hoffman pockets if you want to tie a knot. And as you can see, the lens is now reasonably well centered.
Don't angry me. जो मैं बोलता हूँ वो मैं करता हूँ, पर जो मैं नहीं बोलता हूँ वो मैं definitely करता हूँ.
So as you can see, this patient did really well. First post-operative picture, the cornea is glistening clear, lens is well centered, and the Warangal Rudras are here to fight and win the war. Thank you. We'll come to the final presentation of our fourth team member who had to suddenly leave.
A very good morning, friends in Hyderabad. Thank you so much for your amazing hospitality. And as I was just taking off from the airport, I got this message from Rishi that, Gaurav, you're also part of the OPL team. So where is your presentation and where are you? And I said, oh, Rishi, I think I'll have to just present it from here. He had forgotten to tell me that I'm also part of the OPL. So here goes. I'm sharing my screen. And that's my friend Rishi, who's held an amazing meeting in Hyderabad along with the team of TOS, and just that he forgot to tell me that I was also in the OPL. So from 30,000 feet in the sky, and that's our compare today. And Harshal invited me to perform live surgery at Jaipur recently, and when I was presenting, as you can see here, I was performing. He gave me a hard cataract. He said, Gaurav, I'm giving a really hard cataract to present. And oh God, what is this? Harshal gave me a 65 lakh machine to operate with, and the phaco tip broke, and that was crazy. So that can sometimes happen if you get a situation in. And going on, my next stop for live surgery was with Dr. Kumar at Bombay, and he gave me he said, Gaurav, you have to show a laser cataract surgery. I said, why not? And when we started doing the laser surgery, everything looked great, and I was able to start off the surgery quite nicely. He wanted me to showcase a very good femtorexis in a slightly intumescent cataract, and as we went ahead, everything seemed to be going great. But when I took the patient into the microscope, I couldn't find the rexis. I was shocked. I said, where is the rexis, Kumar? He says, oh, Gaurav, don't worry. Sometimes my machine doesn't make a rexis. So that was really funny. And now I had to just fashion a rexis. The nucleus had been cleaved, but there was no rexis. Well, friends, the learning lesson from here is that very rarely the lasers can malfunction. So it's important to keep them calibrated. And this is one in a few thousand cases of a complication that you can have. And it can be risky because if you have cavitation inside the nucleus, you can have a ruptured PC. So please be watching the screen when you're doing that laser cataract surgery. Going on for my next stop, I was in Hyderabad, and my dear friend Dr. Santosh had invited me to perform live surgery. He said, Gaurav, we'll do a posterior polar cataract. I said, of course. So at the Center for Sight, we started doing this posterior polar cataract. I wanted to showcase an amazing surgery, and as we were running late, for the live surgery program, and I had a flight to catch. He said, Gaurav, you'll have to just show it a little faster. I said posterior polars require a lot of patience, and then the learning message was that you can see here that there is no rotation. I'm taking out the quadrants very nicely. Femto is a great technique for removing these cataracts, and in a very slow pace, you can remove all the chunks without any nucleus rotation and no hydrodissection. You can see that I'm debulking the cataract, and I will be left only with that posterior plate towards the end. You can also see on the integrated OCT on the side at points that I'm now kind of disengaging every piece of cortex from the equator of the bag. And once I've done that, then I have to just remove this last piece. And very patiently, I'm going to do a flotation on the right. You will be able to see the MI OCT images. And there, now the last piece comes up, which floats up. And I've got home, and I have to, then Dr. Santosh tells me, Gaurav, I think you've done a great job. Just implant the lens and leave. Your flight is already, just 1 hour left. So I'm closing up. and I'm feeling I've done a great job. And as I just go to the last step, and there goes the posterior polar cataract gives way. So it's never over till it's over, and you have to keep watching out these posterior polars right till the end. Last stop was in Delhi with my dear friend Dr. Maipal Saitdev. Gave me a very challenging cataract to operate, a hard brown cataract. Again, he wanted to showcase a femto surgery. Everything looks great. I do a femto. And it's also got a lot of phacodonesis. You can see the bag is moving. I mobilized the cataract, and I am able to, with lot of difficulty, complete this cataract with a very, very loose bag. And once it's done, then I'm going to go to the cortex remover. And as I'm removing the cortex, you can see that the view is.
So I think we'll quickly come to the end because we're
Yeah,
running out of time.
Now I'm going to remove the cataract.
As you know, my friend has
I've been
recorded
able to
this from
complete
the
my
air, from the flight. So thank you all, and I hope we managed to entertain you as well as show you some good science. Thank you.
तो हर्षल फाइनल कमेंट्स हो जाएं टीम हाउ वाज द परफॉर्मेंस है क्या है हवा से रिकॉर्ड करते हैं हर वक्त के साथ 4 मिनट हैदराबाद इज यूनिक हैदराबाद इज डिफरेंट हैदराबाद वांटेड ओनली अ 3-minute वीडियो वी वांटेड मोर एंटरटेनमेंट एनी कमेंट्स
Professor Moria?
Hyderabad bouncy pitch is there, so their captain flew away. The pitch is so bouncy, it's just like the English pitches. So he doesn't, he was so afraid of Hyderabadi pitch that the captain left.
So not only cataract, but we manage each and every case. Orbit, extraocular muscles, whatnot. And in ambliopus, everything, Banjara Mavericks.
सर सबसे पहले प्रेजेंट करके बहुत देर से वेट कर रहे हैं सर
See, we have shown something different. Yes, sir.
So audience, there is a very important part of yours. You need to choose who was the best entertainer, winner and runner up. So don't go away.
Yeah.
We'll take audience vote. Please.
The scheme of things is like for the entertainment segment, there are 3 judges who are judging. 60% weightage will be given to the judge's choice. They will be shortlisting this number of participants, and by voice vote of the audience, we shall be deciding who is the winner and who is the runner-up. So that's about the audience thing. Scientific, the 4 judges are. The best winner, the runner-up, the best. Then based on science only, we are going to decide the best team and the runner-up team, and the other 3 teams get the participation trophies.
Okay, so I think we can take for best entertainer by the time judges are deciding. Can we have?
Shortlist करके फिर लेना है.
We know, but still we know.
Yeah.
Dr. Rakesh, can you come here, please? Dr. Rishi. Judges.
यहाँ है entertainment इधर है entertainment इधर है.
बस be here. No mic. सर आइए. तो डॉक्टर राकेश है और कौन है बताइए.
Give us the top 6. Give us the top 6.
Entertainment के लिए audience vote will take.
1, 2, 3, 4. 1, 2, 3, 4, 5.
सर आप इधर आइए. मेरे को मालूम है.
Individual.
Okay. Dr. Vineet, please be here. Dr. Rakesh, yes.
On a serious note, I must really admit, Rishi told me 3-4 weeks back, OPL कर लेंगे क्या? I thought, let me give it a try. So he said, I'll give you Harshul. I said, why not? Oh, then I was enthused. Harshul के साथ करना है. एक जगह LBO है, दूसरी जगह मनोज माथुर. क्या combination बनेगा? So then I thought, I once in Warangal conference, I had done the quiz competition on cricket theme. So Rishi suggested actually, why don't you try something different? So it occurred to me that I must as many cricket terminologies as possible in this OPL for OPL. Then I suggested to all the team members, I must really admit, almost every team, they used cricket terminology to the fullest. And I hope, like all of you, like you must not have experienced this kind of cricket terminology in any of the OPLs before. Arvind, am I right? Wow, so 3 cheers to all the teams. They really use the cricket terminologies in their presentations. And my God, we use those catches to the ultimate. And what I like the most, my personal choice, is Abhilasha's bowl out. How she really compared the 2 segments with the bowl. So that's my personal choice. I'm not influencing the judges.
You're not allowed to vote, sir. Anyways. He's treasure. He can give you a gift if he wants. Okay, so anybody else for best entertainer? Judges?
Judges, we need 1, 2, 3, 4,
Judges,
5. So
yes.
we will add audience voice vote to that, and then we will give the trophies.
Okay, so I think let's take audience vote for best entertainer. We have 3 contenders in this. Dr. Rakesh, not Banjara, it's an individual vote, yes. Dr. Rakesh, Dr. Rishi Swarup, Dr. Vineet. Who else was there entertaining? Anybody left out? No, I think Arvind, Dr. Arvind, and you are scientific, sir. Dr. Arvind, yes. Dr. Hunawar, sir, please come. Dr. Hunawar, yes, yes.
ये है इसकी बड़ी फैमिली संभाल रहा है ये फैमिली मैन.
Okay. So, no, it was quite entertaining, no? Which had very nice entertainment value, yeah. So let's take vote. Audience will shout and raise hand, okay, simultaneously. For Dr. Arvind Maurya, how many?
Ayes.
Okay, let's see. Dr. Santosh Hunawar. Okay. Dr. Vineet. Chairman Scientific Committee. Okay, again. Dr. Rishi Swarup. It's more for Chairman Scientific, huh? Less for Dr. Rishi. How come?
Chairman Scientific Committee.
You have one more year, I guess. Dr. Rakesh. Okay, I think let's take them forward, no?
Yeah, Rishi and Rakesh.
And okay, so
we need one more, yeah. Three के बाद deadlock करेंगे.
No.
अच्छा दो.
Winner and runner-up. I think it was clear, or we need to take again. What do you feel?
नहीं 3.
It's clear. Okay.
Okay. Any
winner, Dr. Rishi Swarup. Thank you. And runner-up, Dr. Rakesh.
Come on,
Can you have the trophies, please?
Trophies. Are the judges okay with our choice?
No. Trophies.
Yeah. So this is audience choice.
Yes, I'll request our Secretary, Dr. Santosh, please.
Yeah.
And judges?
Rishi.
Judges are busy in that, no problem.
Yeah.
Okay.
Come on, photo.
Yes. Okay, runner-up, Dr. Rakesh. वो छोटी है बहुत लिफ्ट करने के लिए.
चलो आप लोगों का everything is done. So science.
Are you ready with the results? No.
ये इनका मिलके था.
एंटरटेनमेंट तो ऑडियंस की. अब बेस्ट साइंटिफिक और बेस्ट टीम
ये सब मिला देंगे. तो ये और ये मिला देंगे इम्पैक्ट. Okay, so it may take a little bit more time because we are going to the impact score with the science score, and then decide the team trophies and the individual winner and the runner-up and the remaining trophies to all. Audience prize were decided by the audience. Nandu?
Okay, we can take opinion by that time.
Yeah,
Sir,
yeah.
your opinion, which is the best team?
No.
No, his opinion. Just why did you like that team?
Impact का total scores दे दो. In the meantime, any comments from the audience, how they felt about the whole thing? I see one empire sitting at the last. She was to be here. Yeah.
Yeah, come, Rishi.
I think I should really appreciate and congratulate Dr. Harshal and Dr. Mathur for really putting up a great show. It was very entertaining. We all know Harshal is quite active and energetic, but to see Dr. Mathur like this was great fun. So I'm in a new avatar. So मजा आ गया. And आपकी हैदराबादी भी सुन ली थोड़ी pure. Everybody got a dose of that as well. Thank you so much on behalf of all of us.
Thank you, Rishi, for giving this opportunity.
So it happened the other way around. I was supposed to be Bade Miyan, he was to be Chote Miyan. Then after Harshal is Harshal, then Manoj Mathur also came up to set an extent here. So I am Chote Miyan, Subhanallah. No. Harshal.
Yes.
Whoa. No.
Audience is done. Entertainment for scientific.
No, we are going to merge the impact score with the science score and then decide the trophies.
Yeah.
हाँ. लिख दिया ना? Yeah. So, yeah. Nandu bhai merge the scores with the science. Harshal, if you remember the lyrics of that, I was really enthused by the Lehrado, the Parcham Lehrado. Excellent, ultimate. Harshal, if you remember the lyrics, please sing for us.
Yeah, please, ma'am. So, judges are here.
Acha, they want.
Yeah, I know this time you people have all been used to seeing this OPL and scoring and other pattern. We are judging on two different facets. The scientific content and the photographic, visual and presentation style content. So we are trying to merge the two and give the scores. And as we looked at it, some of the things that I observed was, it was nice to see some Salvador Dali kind of effects in the visuals by Neha Dholakia.
Rishi.
The upside down surgery reminded me of the upside down pineapple cake. And the rest of it was all very psychedelic, space station and other things. When we were looking at Rajesh Sakya's videos, delightful visuals and comic presentation. We enjoyed the talk as much as the narration of the effect and the effort that went into doing a good job of that surgery. I want to give some of the credit even to his wife. Had she not been after him, he wouldn't have done such a good job of things. He was so scared, was mortified, and therefore he did a wonderful job of the whole thing. As far as Sahiti is concerned, she has done some creative visuals, talking of the Einsteins and the Edison's bulb and some other things where she has used graphics effectively that added to the visual content. So while the narration style and time taken count, some of these hitting you in the eye or grabbing an eyeball kind of effects also add value to the presentation. It might not necessarily add to the score, either of teaching or the illustration for the student, but yes, it will leave a good memory even for the viewer to recollect and reconnect when they come to talk about that particular challenging case. And Siddharth Dikshit, his case also had a challenging value, so the learners and others will know how to face or cope with such a challenge, and the visuals for that were very appropriate. No distraction, nothing, it was directed more at teaching or skill imparting. And in Arup Chakravarti's case, the visual quality of the slides the illumination, the brightness, the exposure value, they were all very well balanced. In some of the others, because of the microscope light or other directional light, there have been some glare and some other things which can probably be modified when a future photography or recording of the surgery is being done. Maybe you can set the parameters of the camera illumination slightly different from the surgeon's microscope illumination. That will cut down the glare and the highlights coming in and kind of sticking out like a sore thumb. And Suchi Smita, again, teaching value. So my observation was that while everybody has done a wonderful job as ophthalmic surgeons, some of you have added entertainment as well as a memory recall value by using good visuals and graphics that a student or an observer will remember and reconnect. Irrespective of the commonality of the surgery or case, those will add a different dimension to the effect.
Thank you so much, ma'am. Dr. Subhadra, your comments, please.
I echo what Vidyavati said, that we are mainly looking at training and teaching and not just the surgeon showing their surgery. But I also want to add that when you are presenting in such a august forum, please take note of your spellings and your grammar, because they will cut marks, because there were so many funny spellings out there. You can edit and correct that spelling. There's no reason for anyone to have even a single wrong spelling on your presentation.
Thank you so much. Dr. Madhukar, your comments, please.
Yeah, it was fun. I mean, adding towards the end a spurt of laughter and everything. It was sportive of all of you to have come up and done. We normally don't do it, so it's fun. Thank you, and you've done.
We need comments from all the judges before we announce the...
Like Madhukar sir said, it's fun, but I think OPL it should be totally fun. Just like Mohan sir does in Chennai, I think it should be more of fun than theory or video alone. Like Madam said, video quality should be a little bit of improvement should be there. Of course, they are good, but they can be better. Thank you.
Dr. Malika, then Dr. Nandkishore.
Well, most of it was cornea, so...
You have a grouse there, lopsided.
But it was good. I mean, it breaks the tediousness of a conference. So I would congratulate all the organizers, everyone. Excellent job, excellent job.
I think diversity also was missing in some places, like only men or only cornea or only lens. So, if you have more diverse, you get more marks.
Dr. Nandkishore.
Only people with hair, some should be without hair. Only people with black hair, So the more diverse you are, the more marks you get.
One other thing, as Dr. Subhadra said, it's not only the spellings, the amount of written matter that goes on one slide shouldn't be too crowded. The letter size should be something, and it should only be to give a cue to the point that you are going to elaborate upon. Please don't hand over your presentation sentences to the audience even before you uttered them. If you put them on screen, the audience reads it even before you are done. While you are trying to talk about it, the audience have already read everything that's there, and they lose that interest. You can't sustain or hold their interest in what's coming next.
Yeah,
just keep a point, not the entire sentence.
Regarding the fun quotient, I think the best part of the program was the dance by Rakesh and Sahiti. That was excellent. And as far as the comments from the opposite teams were concerned, I think they were very bland this time. We are used to more entertaining, more stimulative, more provocative statements from the opposite teams. That would add a lot to the entertainment quotient. So I was trying to interject in between, but normally judges don't do that. So next time we expect more comments, more provocation from the other parties.
The best entertainer was Dr. Manoj Mathur. Hands
Thank you. Coffee law.
I have not seen him dancing like this with abandon. So really, congratulations on your growth.
Though he doesn't get a prize or a trophy.
Great.
None of us get anything. It's always the players who take over the...
I think let's take the decision of the judges. First, we'll start with best scientific video, runner-up, winner. Then we come to team.
The best scientific individual.
Individual, yes.
Individual runner-up.
Okay, never mind.
The runner-up is...
टाई बोले तो स्टार मार्क देखो उनका इंट्रोडक्टरी वीडियो से.
No, we'll give to two. No problem. If it's a tie,
runner-up
we'll
is a
give to
tie
both of
between
them.
Vineet Joshi and Rishi.
Individual.
And the winner...
Just a minute. Let us give the trophies to them. Yeah.
Come.
Runner up.
Runner up, beta.
Runner up.
No. Runner up. Come, both of you.
Both of you
I
take
request
together.
Dr. Vidya. I think Dr. Vidya is the senior most among the audience in here. Yeah, Dr. Vidya will hand over. You are the chief guest to distribute the trophies.
No, all judges.
Come.
Yeah.
Go other side. Yeah. अब दोनों कैसा बांटते देख लो. ऋषि बाद में एक और एक बना देंगे.
एक कप ले लो, एक कप कैप ले लो. And by a rare show of unanimity, I think the winner in the individual event is Siddharth Dikshit. All of us have given the same amount of marks.
That was very innovative. Yeah.
Yeah.
Ma'am, please.
Told you teaching and skill transfer and challenging case.
Very nice.
I remember being on the DMBA examiner panel with him as a coach.
Thank you. Very nice. Yeah.
So Harshal, now what's next?
So, now we have runner-up team and winner team.
The runner-up team is Karimnagar.
Whoa!
चलो कल फेसबुक पे कहाँ पे एक बजे आ जाएगा. इसका सुबह 5 बजे फेसबुक पे में इज विनिंग OPL इन तेलंगाना TOSCON.
मैम
सबको दो सबके लिए एक.
और जजेस प्लीज ज्वाइन. प्लीज कम.
और लोग नहीं देंगे क्या?
सर. Yeah.
Come.
Yes, sir. Okay, so now the most prestigious winner.
Yeah.
Sir, इतना जल्दी नहीं sir.
Congrats, sir.
Yeah. So winner of TOSCON OPL 2024. Any guesses?
Let's take the audience.
Come on. Hyderabad. Warangal. Banjara. Charminar. Okay.
I think the lowest shouting was for Charminar, but the winners are Charminar.
Oh, wow. So we have winners of TOSCON OPL 2024. There's the team, Charminar, led by Dr. Arup, Dr. Suchi, Dr. Madhu and Dr. Dikshit. Congratulations.
Good. Congrats.
Great.
Congrats.
Can we have the trophy?
Trophies?
Sir.
Vidya madam. अच्छा बद्री सर and Vidya madam दोनों.
Madhu sir.
Madhukar. सबका एक है. Everybody one trophy.
Each
All
one
the
of.
four. Yeah.
Sir.
We all hold together. Yeah.
Madam, Vidya ma'am, to Madhu.
Huh. Come.
I think your team can be here
Yeah.
in center and judge can be on back.
Yes. आप लोग आगे आ जाओ. Just come forward.
You come
a
here.
bit. Yeah. Otherwise, you step here.
Yeah.
Similarly, हर का ले लेंगे ऐसा.
Four of you here and judges and
yes.
please, ma'am.
Yes, and we all stand behind. The two anchors at the two corners, please.
एक बीच में खड़े होके ले लीजिए.
All the runners up also come take this snap. या नहीं एक रनर अप का ले लेंगे.
हो गया.
आ जाओ.
दे दिया.
This will be a good shot.
आप जब
हाँ अभी पार्टी
था. सेकंड राकेश. ऑडियंस से वो कराया. हमने इंडिविजुअल किया ना. ऑडियंस से करा के. आज खड़े हो जाए.
नहीं हमारा दोनों मैचिंग कोट्स हैं ना तो क्वाइट द कॉर्नर.
थैंक यू सर. थैंक यू.
Yeah.
Thank you.
Now the participation trophies to the other teams. Participation request.
नहीं
हाँ अच्छा विनर रनर.
इंडिविजुअली था.
वो दे दिए ना पहले ही दे दिए. हो गया. हाँ. अच्छा राकेश कम ऑल द एंटरटेनमेंट ऋषि राकेश और एंटरटेनमेंट का था ना यहाँ पर ये फोटोग्राफ के लिए. हाँ फोटोग्राफ के लिए ऐसे
एंटरटेनमेंट किया वो कर लिया.
आ जाओ बिफोर वी हैंड ओवर द पार्टिसिपेशन ट्रॉफीज. या ये इनका ऑडियंस चॉइस.
इसी के मोबाइल से लो. Madam.
Come on, now we distribute the participation trophies to all the participants. Other participants request everyone to come up. आइए सब. मैडम बद्री सर आप दोनों के. हाँ सुभद्रा दी. हाँ अच्छा.
Come. Give to everybody.
अब इसमें winners तो.
We request all the participants to please
other teams
collect their trophies. All the participants
to come.
Charuta.
All the participants who have not received the trophy, winners and runners up नहीं. हाँ. The 4 teams, the 3 teams, remaining teams to come and collect the participation trophies. 3 more teams. Yeah.
Very nice.
What a dancer. Yes.
Sir, compliment for the customer. You have software and now okay.
Sir, you have
This is just fun.
Sir, only candidate less like it.
Very nice video. Yeah.
Only candidate less like it.
Prizes are judges.
Dr. Charuta. Anybody left? No. बस done. कोई नहीं. चलें सर. So
वैलिडिटी हो गया ना, मजा आया टेक्निकल ग्लिचेस की वजह से.
Hello, good afternoon, everybody. And this is the end of our 9th Telangana State Ophthalmological Society conference. We are going for the valedictory function. Then I request the President of TOS, Dr. Bharat Kumar, please come onto the dais. Bharat Kumar. I request our past President, Dr. Badrinarayana, sir. Dr. Vijay Kumar, Vice President. President-elect, Dr. Vijay Kumar. Vijay Kumar, sir. Joint Secretary, Dr. Praveen. Joint Secretary, Dr. Praveen. Treasurer, Dr. Ravi Kumar. Ravi Kumar, please come on to the dais. Okay. Then Scientific Committee Chairman, Dr. Rishi. Dr. Rishi, come on to the dais. And ARC Chairman, Dr. Modini. Editor Publication, Dr. Srinivas Prasad. So, an exciting moment actually. A large number of delegates have participated in this conference. It is more than 1,000. And exciting thing is there are many abstracts actually, more than 600 abstracts. It's very happy moment that we can celebrate. And every year we are improving year by year. And we expect the next year also we see the same enthusiasm to improve the conference and complete the conferences. I hand over to our President Dr. Bharat Kumar. Please complete the proceedings.
Good afternoon, everybody. So, there are no words to say regarding this conference. It is an excellent, successful conference. So far, we have compared to previous conferences, because the membership is also recordedly more than 1,000. Presentations and presentations and posters also recordedly we have more than 600 members, posters, scientific content, everything is excellent. So I congratulate local organizing committee for their efforts to make this conference success. So next time we are having the conference at Warangal. So Warangal local organizing committee is supposed to take inspiration from this local organizing committee, and they can take advices to make the Warangal conference more successful. Thank you, one and all. Now your may depend. So, okay.
It is really an happy moment that we have completed successfully, and as Dr. Bharat told already, the Warangal people has come forwarded and to conduct the next conference in 2025. So I request our scientific committee chairman, please announce the scientific awards for this year.
Thank you all, and thank you to everyone for helping shape this conference so well. I have to specially thank my scientific team, both the members of the scientific committee as well as the LOC volunteers for the scientific committee. All of you have really helped me, and a special mention to Dr. Charuta Puranik. Where is she? She has really helped me a lot in putting everything together. She was literally like my right hand. And I really like to appreciate all her help in putting up the program. So without further ado, let me go ahead and announce the results of all the competitive sessions from this conference. So I'll just announce them in the order that we got the results. So first day we had V.V. Ramana Rao Grand Rounds session, and the second runner-up is Dr. Seema Kurti Sriram. First runner-up is Dr. Neha Ghosh. If you're here, please stand up and let everybody recognize you. And the first winner is Dr. Akash Belenje. The Swaroop competitive video session, the second runner-up is Dr. Amit Prasad. Congratulations. First runner-up, Dr. Ireti Sahiti. Congratulations. And the winner is none other than Dr. Anil Kumar Mandal. Hats off to him. Congratulations, sir. NS Reddy competitive PG free paper session. Second runner-up is Venetia Grace Fonseca. Congratulations. First runner-up, Pragya Bhattacharjee. And the winner, Thakur Ankita Singh. Congratulations. P. Ramchandar free paper session. The second runner-up went to Dr. Manoj P. Shettigar. Congratulations. First runner-up, Dr. P. Sai Kiranmai. Congratulations. She has been very active in the LOC for this meeting. And the winner is Dr. Vanita Pathak Ray. Congratulations, ma'am. Manoj Mathur poster session. Second runner-up, Dr. Shreya Chahande. All that's pink is not pretty. First runner-up, Bharadwaj Innamuri. Clinical trial, sewing needle microcapsulotomy versus small needle aspiration to avert Argentinian flag sign. And the first prize winner was Shamli Zalke on OmniFlow. Congratulations to all the winners. Drishti Student of the Year, first runner-up, there's only one runner-up, Dr. Rahul Gogineni. Congratulations. And the winner is Dr. Muktika Kondapalli. Congratulations. Dr. Gangadhar Reddy, PG quiz winners. Second runner-up is the team from Sarojini Devi Eye Hospital, Dr. Jonadula Sai Rachna, Dr. Niharika, and Dr. R. Chaitanya Lahiri. The first runner-up is from REH Warangal. Yes, you can, we have cups for them because we'll be giving in this conference. So can the second runner-up team come up and take their prize? I request the chairman of the conference, Dr. Rajlingam, to give away the cups, please. So Dr. Sai Rachna, Dr. Niharika, and Dr. Chaitanya Lahiri. Congratulations. What about the second runner-up doesn't get a check, no? Yeah, only first runner-up and winner will get a check. So first runner-up. Okay. The first runner-up, I request the organizing secretary, Dr. Modini, to give the cups. Dr. Ranjan Sharma, Dr. T. Niharika, and Dr. Sai Divya Reddy from REH Warangal. Congratulations.
They said it was just a chemical spill and it's nothing to worry about.
Congratulations. Each of you will also get a check of 2,500 each, I think. Yes? So they will be receiving that in the next conference or now? Very soon, yes. For the winners, I request the president to come up, Dr. Bharat. The winners are from ESIC Medical College and Hospital, Dr. N. Gitanjali, Dr. Rashmita Somaghani, and Dr. K. Rakesh Kumar. Congratulations to the winners. 3 cheers. Finally, we have Teachers of Tomorrow. So the second runner-up was Dr. Varun Malhotra with the 2 mentees. First runner-up was Professor Y. Raman with 2 mentees. For the second runner-up, the cups can be given. I request our past president to give the cups. Dr. Varun Malhotra with his two mentees. Dr. Sahiti is collecting on behalf of Dr. Varun. Congratulations. The first runner-up was Dr. Professor Y. Raman and two mentees. Congratulations, sir. And the winner was Dr. Subha Prasad and two mentees. I request our Vice President to give to the winner. For best mentee, there is a tie for the first runner-up position. I request Dr. Praveen to give away this trophy between Dr. Subha Prasad and Dr. Sai Kiranmai. Congratulations. Mentor. Best mentor. It's written as mentee. Best mentor. Sorry, it's not a runner-up. It's for the best mentor is a tie between Dr. Subha Prasad and Dr. Sai Kiranmai. Congratulations to both of you. And I request Dr. Ravi Kumar to give away the final one for the best mentee, who is Dr. Farnaz Khan. Congratulations. And the best audience prize goes to all of the delegates who've been very good in attending all the sessions. Congrats. 3 cheers for them. That's it. Thank you.
Before going for the further proceedings, we'll ask some suggestions if anybody wants to talk. Dr. Manoj Mathur, anybody you want? Any suggestions about the conference and this one? Dr. Nandakishore, Dr. Madhukar Reddy, or any audience if they want to give any suggestions to the EC?
I would like to congratulate the local organizing committee. Suggestions I'll give you everybody in person. I would not like to give suggestions at this forum. I must really appreciate the hard work that was put in by Dr. Modini. She got to know that she has to organize the event. Just a few months back when the original venue of the LOC, they said they can't do it. So Rajlingam had to constitute an LOC from the TOS itself, and I must appreciate the efforts of everyone. Like they've constituted different subcommittees, and everybody worked hard, including the committee that was allotted to Rishi, Charuta, Arvind, and the other scientific committee members. They all did their best, and the scientific committee, the scientific program for this conference overall, if you just give a glance to the entire spreadsheet, you will be all unanimous in appreciating the tremendous work put in by this committee. And we had topics covering all segments of ophthalmology. All in all, a wonderful conference, a good conference. I hope Warangal will take the tempo forward next year. Thank you.
The most important thing here was that they had very short time, and this was the first time I think Modini was taking full responsibility as an organizing secretary. But we are really very happy with the amount of hard work you put in, all of you. Rishi also had very little time. And one thing which we appreciated very much was Dr. Bharat's presidential address. It was very concise, very up to the point, and then whatever he wanted to say, simple things, he put it in a very nice fashion. So congratulations, Bharat. We hope from here, I mean, like they ask us for less and less advice, because we see that the team is shaping up very well, and I don't think all of you would require too much assistance from any of us in future. So congratulations to all of you. Did a great job, fantastic conference. Shortcomings will be there in every conference. I think we need to learn from them rather than make a critical analysis of that. So I hope we learn from these small hitches here and there and go ahead with a very bright future. Thank you.
So thanks to the TOS all members for showing faith in the LOC and allowing us to be part of this wonderful planning. It takes a tremendous amount of effort to organize a conference, and from the last 2 years I'm experiencing this, the level of work that goes in from at all levels. And thanks to Dr. Rishi that he allowed me to be part of the scientific program planning and doing all the work. So I think all in all, like Dr. Nandkishore also said, that whatever the shortcomings, please forgive us. I want to make a special thanks to all the LOC members whose efforts are may have gone unnoticed from the rest of us or the rest of everybody. So very big applause for all the LOC members. So we look forward to the next conference, and thank you again for giving me opportunity to speak.
Anybody? PGs, faculty, anybody? So now we'll proceed for the memento presentation to the LOCs. I request Dr. Bharat, please hand over the mementos. Dr. Kasuprasad Reddy is not there. Sharad Babu, Dr. Sharad Babu. I request Dr. Nandakishore sir, patron, to take the memento. Request Dr. Manoj Mathur sir. Dr. A. Ravindra, advisor. Dr. Jagan Mohan Rao. Dr. Badrinarayan, please come. Dr. Jagan Mohan Rao. Dr. Badrinarayana. I request Dr. Badrinarayana hand over the memento to our President Bharat Kumar. Dr. Vijay Kumar. Chairman LOC Dr. Rajalingam. Myself. Next, Dr. Y. Raman, Co-Chairman. Dr. P. Modini, Organizing Secretary. Dr. Umesh. Dr. Sai Kiran Mai. Dr. Rishi Swarup, Chairman Scientific Committee. Dr. Arvind Maurya. Dr. Charuta. Dr. Navya Cherpuri. Dr. Ravi Kumar. Dr. Rita Bisha. Dr. Vijay Lakshmi. Dr. Pri Praveen. Dr. Shivakumar Uriti. Dr. Deepak Kumar Reddy. Deepak Kumar Reddy. Deepak Kumar Reddy. Dr. Malat Christina. Dr. Sachindra Reddy. Dr. K. Kavita. Dr. P. Satyavani. Dr. Uma. Dr. Varun Malhotra. Dr. Pratima. Dr. Anjani Pratap. Pratima. Dr. K. Seniormost Prasad, Dr. Madhuri, Deepak Kumar Reddy, Deepak, come. Thank you very much, all the LOC members, for your effort and hard work. I request Dr. Modini to give a vote of thanks.
It's my pleasant duty to thank everybody who were a part of this conference and made it a thumping success. As we wind up this conference, it's a feeling of achievement. And if I'm honest, a feeling of relief also, because it was a whirlwind 3 months with lots of activity, which bore fruit in the last 3 days, which all of you could see. In the month of March, it was decided that we at TOS and will conduct the conference, and at that too at Hyderabad. Our visionary, Dr. Rajalingam, who is the TOS General Secretary, decided to come up and take up the chairmanship of the LOC, with the help of Dr. Raman and his experience in the last conference, which was beautifully done at Citadel. He reposed his confidence in me and my ability and capacity to take up the post of organizing secretary. We compensated the lack of time by deputing various tasks to delegating and deputing to many committees. We had a mammoth jumbo LOC consisting of 34 people, who each one brought their varied talents and strengths to make the conference a grand success. Dr. Kiran, I want to thank each one of them personally. Dr. Kiran Mai is a hard worker and has spent many nights on doing many things which required to be done. I would get a message early in the morning, ma'am, done. So I will thank you, Kiran, for all your work. Dr. Umesh brought his cheerful enthusiasm to the team, which helped us to keep our morale up. Dr. Rishi and team worked magic with the scientific program. It's like Maggie 2-minute noodles, man, 2-month noodles, and everybody likes it. Charuta was a great support and a great contact also. She would, many of the things we would confer with her many a times. Dr. Arvind and Navya brought their special abilities to crafting of the scientific program. It was very enriching and had many symposia, instruction courses, competitive events and everything. It is with pride I share that the number of submissions this time were maximum, so also each and every hall was full, packed full, the delegates were standing. And we had 5 halls this time, not like any other conference. So I congratulate Dr. Rishi, Charuta, Navya and Arvind for this grand success of the scientific program. If the scientific program is the heart of any conference, the budget is the soul. Dr. Rita, with the help of Dr. Vijay Lakshmi and Dr. Ravi, promptly computed our accounts, and you'll be pleasantly surprised that July TDS is already filed in time, before the conference.
Congratulations.
Dr. Shiva, Praveen and Deepak were taking care of all the accommodation and transport. Thank you for making our ride smooth, literally and figuratively. Absolutely did not have to look into all that, did a very good job, all 3 of you. Hip hip hooray. Such intense mental activity needs to be supported by food. Dr. Sachindra, Dr. Malati, Dr. Kavita all took care of our taste buds and nutrition very, very efficiently. Dr. Sachindra crafted the menu, talked to the hotel people, and it was really a good spread. Thank you so much for managing everything. The cultural team of Dr. Satyavani and Uma surpassed themselves by bringing a wonderful evening of entertainment involving local talent of our PGs. And the crowning glory, of course, was Dr. Rajalingam's DJ Tillu. That was an excellent touch, sir. It really made us very happy, and it was like the crowning glory of the conference. The audiovisual relay in every hall was perfectly managed by Dr. Anjani, Dr. Pratima, Dr. Varun and team. I must thank my postgraduates here who were a big help to Dr. Anjani. Everything went very, very smoothly. We had a large number of wet labs this time, almost 12, spanning all the subspecialties, which were very meticulously planned, micro-planned by Dr. Srinivas Prasad and Dr. Madhuri. Give her a big hand, he is not here. She did a lot of planning, a lot of this thing, and here I must also acknowledge the support of Appasamy, My Healthscape, Aurolab, Zeiss, Lika, Ravix Biosciences, who helped us with their machines for the wet lab. All the students appreciated the wet labs a lot. All my postgraduates, thank you from the bottom of my heart for bringing your enthusiasm, energy here. You worked excellently in the background, in the foreground, and in the cultural event. Would not have been a success without you, and I'm glad all other PGs from other colleges have come. You are the conference is mainly for you, so it is good that all of you participate. I wish to record my appreciation for our friends in the pharma and surgical fields whose participation enhanced our conference. The WhatsApp group we made, Vijay Lakshmi and me made a group with the trade, because we had to communicate in a short time everything. You won't believe it was the most active group. Night, day, all the time messages running back and forth. Madam, what is the height of the stall? What is the size of the stall? When will we get it? Who's the fabricator? I'm going to miss that group. After I dismantle it, definitely going to miss that group because it was very active. I thank our event team, Madan, Srinu, Sushmita, Ajit, Viranchi, Kaleem, Bashiruddin, all of whom coordinated about the certificates, lineards and everything, and were very prompt. In fact, even today Sushmita gave me 20 certificates on the spot for this kit competition. Appreciate that. I might have scolded you people a bit. And all the other people of the team whom I don't know by name, but your presence was very comforting in the halls. That anything goes wrong, you will take care. Thank you all. I also thank Gulzar and Suresh for taking care of all the registrations and being in constant communication. I think I must have rung Gulzar more than I ring my husband during these last 3 days every day, because I had so much information to ask from him. The hotel staff were marvelous. I thank Mr. Surya Prakash, then the hotel manager, for cooperating with us, for correcting a few deficiencies which are inevitable in a project of this size. And we liked your food and the stay was comfortable. Thank you so much. Shiva, I cannot forget, because he is our support system at Sarojini, who helped us to type the invoices for the company, and he was our man of all, jack of all trades. Thank you, Shiva, from the bottom of my heart. I also cannot miss to thank the contributors to the souvenir. There is a big list, but I want to specially thank Dr. Kasu Prasad Reddy, who from the US coordinated, communicated with me. Thank you, sir. I put on record. And to all the others, it is not to say that I am not thanking all the others. I have forgotten my list in my phone, so I am not going to read. But I thank all of you from the bottom of my heart for helping us to make this conference what it was. In the end, I can only say, hip hip, hooray!
National anthem, okay? National anthem. So before the national anthem, please stand up for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
जय हिंद।
To record my thanks to my family who were with me throughout this journey, because I was not able to give them much time. On the reverse, they were trying to ask me every minute, every time, even they called me the last 2-3 days, my son also, do you need anything? Do you want anything? So I thank them.
So, LOC members and EC members, please come over the dais for a snap, for a photograph.